Before getting into the various types of anemia, we need to understand the RBC indices. RBC is your red blood cell and indices is nothing but the plural of index. So these refer to the various features related to RBC. For example, the total volume of RBC present in your blood, or the total number of RBC present in your blood, or the concentration of hemoglobin present in your blood, or more specifically for a single RBC, the volume of single RBC, the amount of hemoglobin contained in that single RBC, or the concentration of hemoglobin contained in that single RBC. So you need to know about all these features. Why? Because once I get into the various types of anemia and start explaining the features of this anemia, also once I start comparing the features of various types of anemia, I'm going to use these RBC indices. So these RBC indices are important in order to understand the various features of an anemia and to compare the features of one anemia with another anemia. So these terms are going to be frequently repeated throughout this video. So I'm going to make the concept clear cut now itself, understand everything related to RBC indices. There are altogether 6 indices that you need to know. 1, 2, 3, 4, 5, 6. First is packed cell volume, which is also called hematocrit. Second is red cell count, which I'll be referring as RCC. Third is hemoglobin concentration. Fourth is mean corpuscular volume for one RBC, mean corpuscular hemoglobin of one RBC, mean corpuscular hemoglobin concentration of one RBC. Now let's look at all of them one by one. First, packed cell volume, PCV, which is also called hematocrit. What I do is take a test tube. This test tube is filled with 100 ml of blood which I have drawn from a healthy individual. To this 100 ml of blood, I add an anticoagulant. Why? In order to prevent coagulation of blood from occurring. Then I put this test tube in a centrifuging machine. In the centrifuging machine, the test tube, it spins round and round and round, and due to the centrifugal force, the heavier particles of the blood, they settle down, while the lighter portion of the blood, they float on top of the heavier particle. Simple class 10 plus 2 concept. Alright, so once centrifugation has occurred, in this 100 ml of blood, what happens is that the portion of the blood that is heavy, which is obviously the cells, they settle down, and the portion of the blood that is light, which is obviously the plasma, it floats on top of the cell. The plasma, it composes 55% of the blood. The cells, they compose 45% of the blood. The packed cell volume is the volume that is formed by these cells that are packed at the bottom of the test tube. So these cells, they form the packed cell volume. And as you can see, 45% of the complete volume of the blood is formed by the packed cells. So the packed cell volume is going to be 45% of the total volume of the blood. In this particular experiment, I have taken or I have drawn 100 ml of blood. So out of this 100 ml of blood, 55% or 55 ml is plasma, and 45% or 45 ml is the volume that is formed by the cells packed together, the packed cell volume. Okay, now this is the true definition or the mathematical definition. Packed cell volume is the volume of RBCs packed together per unit volume of blood. So you have your volume of blood. This is the volume of blood. Out of this total volume of blood, how much volume is formed by RBCs that are packed together? In this case, we have taken 100 ml of blood, and the amount of the volume of RBCs packed together is 45% of 100 ml, which is 45 ml. So it comes out to be 0.45. So the packed cell volume in a normal individual is 0.45. What does this mean? Okay, so if we take 1 ml of blood, 45% of 1 ml, which is 0.45 ml, is going to be composed of red blood cells. If we take 1 liter of blood, 45% of 1 liter, which is 0.45 liter or 450 ml, is going to be composed of red blood cells. So if packed cell volume is 0.30 milliliter per milliliter, what does this mean? It means that for every 1 ml of blood, we have 0.30 milliliter of red blood cells. Got it? One last time. What is packed cell volume? Packed cell volume is the volume of red blood cells packed together per unit volume of blood that we have taken. So let's say if we have taken 100 ml of blood, then in a normal blood, out of 100 ml, 45% or 45 ml of this 100 ml is going to be the volume of red blood cells. If we have taken 1 ml of blood, 45%, that is 0.45 ml, is going to be red blood cells. If we have taken 1 liter of blood, then 45%, that is 0.45 liter or 450 milliliter, is going to be the volume of red blood cell. And what is that? That's your packed cell volume. Whew. Okay, second is red cell count. Nothing but the total number of red blood cells present in unit volume of blood. So we take the total number of red blood cell, we divide it by total volume of blood, and then we get the red cell count. In a normal person, 1 ml of blood contains 0.45 ml of packed cell volume. How do we know that? We know that from this concept right here. And this same 1 ml of blood also contains 5 million red blood cells. So let's say I have taken a test tube, and this test tube right here contains 1 ml of blood. In this 1 ml of blood, if you were somehow able to count individual RBCs one by one, you'd find that there are altogether 5 million RBCs. And if you are somehow able to measure the volume of all those RBCs, you'd find that they compose 0.45 ml of the blood. So that means 0.45 ml of this blood contains 5 million of RBCs. Okay. Next up, hemoglobin concentration. Simple thing, you know how to find concentration. Take the amount, divide it by the volume. So in order to find hemoglobin concentration, you take the total amount of hemoglobin and divide it by the volume of the blood that you have taken. So for example, if you have taken 100 ml of blood, in this 100 ml of blood, you are going to find X gram of hemoglobin, right? Then the concentration of hemoglobin is going to be X gram per 100 milliliter of blood. Now, the lower limits of the hemoglobin concentration for different age and gender are given right here. From this, I also want to say that the hemoglobin concentration present in the blood of an individual is dependent on two things: the age of the person and the gender of the person. So let's look at the hemoglobin concentration of different ages and genders. In case of newborn, be it male or female, the concentration of hemoglobin is 15 milligram per 100 ml of blood. However, in adult male, 13 gram per 100 milliliter of blood. Adult female, it is less, 11.5 gram per 100 milliliter of blood. So let's say you draw blood from a person, you perform investigation on it and find out that the hemoglobin concentration in the blood of the person that you have, the blood that you have drawn, is 12 gram per 100 ml of blood. So the hemoglobin concentration is 12 gram per 100 ml of blood. Now, is the person anemic or not? Before that, in anemia, the concentration of hemoglobin in the blood is less than the lower limit. So there is a certain range of hemoglobin concentration, right? From this much to this much, from lower limit to higher limit. If the hemoglobin concentration in the blood of the person is less than the lower limit, then obviously the person is anemic. And what I have here are the lower limits in different ages and gender. Okay, I said that the hemoglobin concentration of the blood that I have just drawn is 12 gram per 100 ml. So can you say whether the person is anemic or not? No, you can't. The reason being the lower limit differs as per age and gender. So you have taken 12 gram per 100 ml, right? For adult male, 12 is less than 13. So adult male is anemic. It is 12 is less than the lower limit. In adult female, 12 is greater than 11.5. That is, it is more than the lower limit. So the adult female is not anemic. In newborn, 12 is less than 15, or the given value is less than the lower limit in newborn. So the newborn is anemic. Okay. Now that we have seen three different indices, packed cell volume, the volume of RBCs packed together per unit volume of blood, red cell count, total number of RBCs per unit volume of blood, and hemoglobin concentration, amount of hemoglobin present per unit volume of blood. Using these three different indices, we are going to find out the rest of the indices that are for single RBCs. These three indices were for your certain sample of blood, but now we are going to look at a single RBC from that sample of blood. First, mean corpuscular volume. Simple. It is the mean volume of a single RBC. How will you find mean volume of a single RBC? Take the total volume divided by the total number of RBC. Done. So you have the total volume, which is packed cell volume, divided by the total number of RBC, which is red cell count. So let's say if I take 1 ml of blood, 1 ml of blood, this 1 ml of blood is going to contain 0.45 ml of RBC and 5 million numbers of RBC. So divide 0.45 ml by 5 million. You are going to get 90 femtoliter. So 90 femtoliter is the mean corpuscular volume of red blood cell. That is, if you take a red blood cell from your body out and look at the volume, find out the volume of this red blood cell, it is most likely going to be at the periphery of 90 femtoliter. Got it? Okay. So on the basis of volume of the red blood cell, they are of three types. Normocytic, cytic refers to, remember, cytic refers to size. Normo means normal. Microcytic, cytic means size, micro means smaller than normal. Macrocytic, cytic means size, macro means larger than normal. So normocytic RBC have mean corpuscular volume of 90 plus minus 10 femtoliter. That is from 80 to 100 femtoliter. But then if the volume of the RBC is less than 80 femtoliter, it is smaller than normal, it is microcytic. But if the volume of the RBC is greater than 100 femtoliter, it is larger than normal, it is macrocytic. Next, mean corpuscular hemoglobin. Amount of hemoglobin, the mean amount of hemoglobin present in single RBC. So simple, take the total amount of hemoglobin divided by the total number of RBC. You are going to get mean amount of hemoglobin present in one RBC. Total hemoglobin by total RBC. So let's say I draw 100 ml of blood. This 100 ml of blood contains 15 gram of hemoglobin and 1 ml of blood contains 5 million RBCs. 100 ml contains 5 million times 100 RBCs. So you divide 15 gram by 5 million times 100 RBCs. You are going to get 30 picogram. So the average amount of hemoglobin contained in a single RBC is 30 picogram. Finally, mean corpuscular hemoglobin concentration. This is the concentration of hemoglobin, not the amount. The amount is mean corpuscular hemoglobin. So if you take out one RBC, it is going to most likely going to contain, if it is normal, 30 picogram of hemoglobin. This is mean corpuscular hemoglobin concentration. So the concentration of hemoglobin, that is amount of hemoglobin per unit volume of RBC. Okay. How do you do that? So you are finding concentration. What do? You take the mean corpuscular hemoglobin, that is in one single RBC. You take out one single RBC, the amount of hemoglobin present in this one single RBC divided by the volume of that one single RBC. Obviously, you are going to get the amount of hemoglobin present in per unit volume of that RBC, right? Array, you take out one RBC, you find out the total total amount of hemoglobin present in that RBC. You find the total volume of that RBC. You divide the total amount of hemoglobin by the total volume. You are going to get hemoglobin in unit volume of that RBC, and that is your mean corpuscular hemoglobin concentration. In other words, you can say take out total amount of hemoglobin in blood divided by the total volume of red blood cell. So in unit volume of red blood cell, how much hemoglobin is there, you are going to find it, right? Okay, so let's say you have taken 100 ml of blood. 100 ml of blood contains 15 gram of hemoglobin, and it also contains 45 ml, 45%, which is 45 ml of volume of red blood cells. So you divide 15 gram by 45 ml. So you are going to find in unit volume of red blood cell how much hemoglobin is there. That is hemoglobin concentration, and it comes out to be in percentage 33%. Okay, on the basis of hemoglobin concentration of single RBC, there are three types. 1, 2, 3. Normochromic. Chromic refers to color. Remember that color. Normal. Hypochromic, hypo less, chromic color, less colored. Hyperchromic, hyper more, chromic color, so more colored. If you look at a normochromic red blood cell, which is a normally colored red blood cell, you will find out that it is peripherally red, right? RBC, a typical RBC, here's your typical RBC, it is peripherally red. The reason being the RBC is not completely filled with hemoglobin. So here's your RBC, it is not completely filled with hemoglobin. The hemoglobin is present at the periphery of the RBC. So the hemoglobin is present at the periphery of the RBC. Centrally it is pale. So we call it central pellar and peripheral red. What do we have here? We have the peripheral red and the central pellar. Okay, first things first. In a normochromic RBC, MCHC is normal, 33%. The peripheral red is 2/3 and the central pellar is 1/3. So 33% of the hemoglobin present in this cell forms 2/3 of the peripheral red of the cell. Let's say the concentration, that is in per unit volume of the same RBC, the amount of hemoglobin is less. Here in per unit volume, there was certain concentration C. Now in this per unit volume, in this per unit volume of RBC, the amount of hemoglobin was, let's say, A. In this per unit volume of RBC, the amount of hemoglobin A is less as compared to this. There is less hemoglobin for the same volume, less hemoglobin. That means less concentration. If there is less concentration, MCHC is less than 33%. Obviously, the peripheral red is going to be thinner because there is less hemoglobin for the same volume. It is going to be less than 2/3, and the central pellar, it is going to be larger. That is, it is going to be greater than 1/3. Similarly, in hyperchromic, there is more hemoglobin for the same volume, more concentration of hemoglobin. So MCHC is going to be more than 33%. The peripheral red is going to be more than 2/3, and the central pellar is going to decrease, and it is going to be less than 1/3. Based on these various features of RBCs that we saw just now, we have three major types of RBC that we are going to find in different types of anemia. Let's look at them. First is microcytic hypochromic. Micro, small cytic size. So the size is smaller than your normal size. The size of the RBC is less than 80 femtoliter. Hypo, less chromic color. So MCHC is less than 33%. Normocytic, normal sized. So the size of the RBC is normal, 80 to 100 femtoliter. Normochromic, normal colored, that is the MCHC or the hemoglobin concentration in a single RBC, it is going to be 33%. With peripheral red, which is 2/3, and the central pellar, which is 1/3. Macrocytic normochromic. Macro, large cytic size is going to be larger, so it is going to be more than 100 femtoliter. Normochromic, normal colored, so MCHC is going to be, why did I write more than, it's supposed to be equal to, let me okay, so change that mistake. All right, MCHC is going to be 33%, that is, there is going to be peripheral 2/3 red and central 1/3 pallor. Here you go, here are all three types. So first you have microcytic hypochromic. Now here's the thing, let's say you draw blood, make a smear on a slide and observe it under a microscope. Now how will you find out whether the RBC is microcytic, normocytic or macrocytic? You can't, it's really difficult, or I don't even know how you are supposed to measure the volume of single RBC. Instead, what technicians do is that they compare the volume of single RBC, or the size. They compare the size of single RBC with small lymphocyte. This in purple is the small lymphocyte and these are your RBCs. So what they do is compare the size of RBC with the size of small lymphocyte. So lymphocytes and RBCs, they have comparable size. So if the size of the RBC is comparable to that of lymphocyte, it is normocytic, less microcytic, more macrocytic. Okay, that's for size. What about color? So in case of color, I said that there is peripheral 2/3 red, central 1/3 pallor. So the peripheral red is more than the central pallor. So you just observe whether or not the peripheral red is more than the central pallor. And you might say, what if it is really more than central pallor, that is more than 2/3? That is hypothetically, that is just hypothetical. It is not possible except for exceptions like spherocytosis, which I'll get into later on. But here's the concept. For size, compare with the lymphocyte. For color, see whether the peripheral red is more than the central pallor. So first, you have this RBC, obviously the size of which is less than the small lymphocyte. So it is microcytic. You can see that the peripheral red is less than the central pallor. So it is hypochromic. Second, the size is comparable to size of the small lymphocyte, normocytic. The peripheral red is more than the central pallor, normochromic. Third, the size is greater than lymphocyte, so it is macrocytic. The peripheral red, it is more than the central pallor, so normochromic. So finally, we are into the topic of the video, and that is anemia. First, what exactly is anemia? I have right here two different definitions, one from Robbins and another from Hirschman. Robbins defines anemia as per the red blood cell mass. Hirschman defines anemia as per hemoglobin concentration. So according to Robbins, there's your blood vessel. Inside blood vessel are circulating red blood cells. These circulating red blood cells have their own mass. That's your red blood cell mass. If red blood cell mass is below the lower limit in an individual of a particular age and gender, then that individual is said to be anemic. Again, so there's your red blood cell with their own mass, red blood cell mass. If red blood cell mass is below the lower limit, there is obviously a certain range of red blood cell mass in an individual from this much to this much, from lower limit to higher limit. If the red blood cell mass is below the lower limit, then the person is said to be anemic. However, the problem is that practically it is really difficult to measure red blood cell mass. So what we do is we use a secondary parameter, and that secondary parameter is hemoglobin concentration. Because hemoglobin concentration has a direct relationship with RBC mass. That is, hemoglobin concentration is directly proportional with RBC mass. If RBC mass decreases, hemoglobin concentration also decreases. How? What is RBC? RBC is nothing but a bag filled with hemoglobin. So if there is decrease in RBC mass, there is decrease in mass of the hemoglobin per unit volume of blood, right? RBC is nothing but bag filled with hemoglobin. RBC decreases, the amount of hemoglobin present in the blood also decreases, hemoglobin concentration decreases. So there is direct relationship between the two. So we can define anemia in terms of what Mohan mentions. That is, anemia is when there is decrease in hemoglobin concentration below lower limit in an individual of a particular age and gender. Okay, see, in all types of anemia, remember, in all types of anemia, there is decrease in hemoglobin concentration. Now, the thing is, in both these definitions by Robbins and by Hirschman, I've been emphasizing in one particular stuff. That is, see, according to Robbins, there is decrease in RBC mass for it to be called anemia. According to Hirschman, there is decreasing in hemoglobin concentration to be called anemia. But then, what is taken into consideration is the age and gender of the individual. The age and gender of the individual. Why? See, the hemoglobin concentration has to be below the lower limit for the person to be anemic. However, this lower limit of hemoglobin concentration is variable. It depends both on the age and gender of the person. For example, let's say I'm trying to diagnose a person whether or not the person has anemia. What I do, I take out the blood, I make a smear on the slide, I carry out CBC, and then I find out the hemoglobin concentration. And then I compare this hemoglobin concentration with lower limit. If it is less than lower limit, the person is anemic. If it is more than lower limit, the person is not anemic. However, how do I know the lower limit? That means I know the lower limit, but in order to compare the hemoglobin concentration with the lower limit, I need to know what's the age of the person and what's the gender of the person. See, this is why. In a newborn baby, be it male or female, the lower limit of hemoglobin concentration is 15 grams per deciliter. However, in adult male, it is 13 gram per deciliter. In adult female, it is 11.5 gram per deciliter. The lower limit is different as per age and gender. So let's say if this smear contains 12 gram per deciliter of hemoglobin, then if that person whom I am diagnosing is newborn, then the newborn baby is anemic because 12 is less than the lower limit 15. But if he is a male, he's still anemic because 12 is less than the lower limit 13. But if she is a female, then she is not anemic because 12 is greater than the lower limit 11.5. The final conclusion is that what is anemia? So anemia is when the red blood cell mass or the hemoglobin concentration in an individual of a particular age and gender is below the lower limit. Alright. Next, the symptoms and signs of anemia. Symptoms are what the patients complain of. Signs are what are seen by the doctor after examination of the patient. So these are the symptoms that are common or general in all types of anemia. So you can mention these symptoms in all types of anemia. So what happens in anemia? In anemia, again, there is decrease in hemoglobin concentration. What does hemoglobin do? It carries oxygen. So if hemoglobin concentration decreases, oxygen carrying capacity decreases. Who needs oxygen? Your tissue needs oxygen. Why? In order to produce ATP. So if there is less oxygen, there is less ATP. What is ATP? It is the energy currency of the body. So if there is less ATP, there is less energy. Why do you need energy? To do work, to exercise. So if there is less energy, you want to be able to do work for a longer period of time. You will get tired easily. So the symptoms are lethargy, tiredness. For muscle contraction, what do you need? You need ATP. If there is less ATP, you will feel muscle weakness. Muscle contraction won't take place for a long period of time. In old age, problems related to heart occur, like cardiac failure, pain in the chest due to cardiac problem, angina, and intermittent claudication. What is intermittent claudication? Intermittent means with gap, and claudication means muscle pain. So in intermittent claudication, the muscle starts paining. The muscle pains when used, when you can, so you use the muscle pains. You don't use the muscle, you rest the muscle does not pain. You again use the muscle pains. You again don't use the muscle does not pain. So there is muscle pain or claudication with gap or intermittent claudication. What is intermittent claudication? There is pain in the muscle when muscle is used, and the pain subsides, or the pain it disappears when the muscle is rested. Signs, the most important sign is paleness or pallor, because there is decrease in hemoglobin concentration. Where at which sites do you see pallor? So you see pallor in conjunctiva, you see pallor in tongue, you see pallor in nail bed, you see pallor on palm. Then you have classification of anemia. Anemia is classified on two different bases. One, there is morphological classification. Simple. This is on the basis of morphology of RBC. How exactly does RBC look? That is the color and size of the RBC. There are three different types of anemia on the basis of the morphology of the RBC. Microcytic hypochromic, normocytic normochromic, macrocytic normochromic. I have already mentioned all these three types earlier in the video. Then pathophysiological classification, where anemia is classified on the basis of the cause of the anemia. How exactly is anemia caused? So there's anemia due to blood loss, or anemia due to decreased production of RBC, or anemia due to increased destruction of RBC. Either way, there is decrease in the mass of the red blood cell. As a result, there is decrease in the concentration of hemoglobin, leading to anemia. First, you have morphological classification: microcytic, normocytic, macrocytic. Normocytic further of two types, whether or not there is high reticulocyte count or low reticulocyte count. Then you have pathophysiological classification, that is anemia due to blood loss. The blood loss can be acute, that is there is large amount of loss of blood in a short duration of time, like if accident occurs, some kind of trauma occurs, or during surgery. Chronic, that is little amount of blood is lost over a longer duration of time, like hookworm infestation in intestine, menstruation, piles, ulcer. Then anemia can be due to decreased production of red blood cell itself. Now decreased production or due to defect in production can be due to defect in three different parts. First, let's look at the production itself. So here's the production of your red blood cell, which is erythropoiesis. So in erythropoiesis, you have your stem cell in the red bone marrow. This stem cell, it changes morphologically into different types of cells and finally form your red blood cell. This series of various morphologically changed cells, this series right here is called erythroid series. So as you can see in the erythroid series, there's your nucleus in stem cell, and then there's your cytoplasm of stem cell. As nucleus matures, side by side, cytoplasm also matures. Nucleus matures, side by side, cytoplasm also matures. Nucleus matures, side by side, cytoplasm also matures. Nucleus matures, cytoplasm matures, nucleus matures, cytoplasm matures, and the nucleus is finally ejected out and you get a reticulocyte that finally forms the red blood cell. So what's important here is that nucleus and cytoplasm maturing side by side. Defect in the maturation of nucleus, defect in the maturation of cytoplasm, or the defect in the stem cell itself can lead to defect in the production of red blood cell, leading to anemia. So decreased production or defect in production either due to cytoplasm defect or nuclear defect or stem cell defect. What is cytoplasm composed of? What is here? What is present here? Hemoglobin is present. Hemoglobin contains two parts, heme and globin. So the defect can either be in heme or the defect can either be in globin. So heme or globin. See, cytoplasm defect, cytoplasm contains hemoglobin. Hemoglobin contains two parts, heme and globin. Defect can either be in heme or defect can be in globin. So in iron deficiency anemia, there is low iron. Due to low iron, heme production is low because heme is composed of iron. So there is heme defect. In sideroblastic anemia, iron is sufficient, but then the enzyme required for iron to be utilized for the formation of hemoglobin is low. So there is low enzyme, hemoglobin is not formed. In thalassemia, globin defect is there. Similarly, nuclear defect is seen in megaloblastic anemia. Stem cell defect is seen in aplastic anemia. High destruction is seen in hemolytic anemia. The name says itself, hemolytic, hemolysis. Now let's get into the various types of anemia. And the very first type is the most common type of anemia, and that is iron deficiency anemia. As the name suggests, iron deficiency anemia is caused due to deficiency of iron in human body. How does a deficiency of iron lead to anemia? See, for the formation of hemoglobin, two components are required, heme and globin. And for the formation of heme, iron is required. So if there is lack of iron in body, there is defect in production of heme and there is less production of hemoglobin. So less iron leads to less heme and less heme leads to less hemoglobin. And what is the condition where there is decreased concentration of hemoglobin below the lower limit in blood of your body? That's your anemia. So that is how iron deficiency leads to anemia. See, under pathophysiological classification of anemia, we had various causes of anemia, and one of the causes was due to defective production of red blood cell. Now, there can be defective production of red blood cell either due to defect in cytoplasm production, or due to defect in nucleus, or due to defect in stem cell that lead to the formation of erythrocyte itself. Cytoplasm is composed of hemoglobin, and hemoglobin contains two parts, heme and globin. So cytoplasm defect can occur due to defect in production of heme, and the anemia in which defect in production of heme takes place is iron deficient anemia. The reason being, iron is required for the formation of heme. So if there is deficiency of iron, there is defect in heme production, there is defect in cytoplasm production, there is decreased production, and you have anemia. Alright, so that was it for introduction. Iron deficiency anemia is the most common type of anemia, and it is also the most common nutritional disorder seen widely in developing countries, because it is in developing countries where people with very low socioeconomic status survive, and they end up not being able to satisfy their iron demand, the daily requirement of their iron in their diet. Okay, so the first thing was introduction. Second is a normal iron metabolism. You first intake iron. This iron enters your gut. It then gets absorbed, reaches the blood. Through the blood, it gets transported to different parts of the body where iron gets utilized, and the excess of iron gets stored in your body. The process of absorption of iron is also regulated. So these are the various steps included under normal iron metabolism. First, iron is taken in, then it gets absorbed in the gut, then it gets transported through blood to different parts of the body where it gets used, and then the excess gets stored, and finally the process of absorption is regulated. First, iron intake. So there are two different sources of iron. You can get iron from animal product. The type of iron you get from animal product is heme iron, and you can also get iron from plant product. The type of iron you get from plant product is non-heme iron, which is also called inorganic iron. Now, the difference between heme iron and inorganic iron is that heme iron is directly absorbed into the enterocyte of your gut. See, there's your stomach and then there's your duodenum. It's in the duodenum where iron gets absorbed. The duodenum, it is lined by the cells of the intestine, which is called your enterocyte. Iron is to be absorbed into the intestine, into the enterocyte, then it goes in finally into the blood and then transported to different parts of the blood. Heme iron is directly absorbed inside the enterocyte. It is directly absorbed inside the enterocyte. However, inorganic iron, it is present in ferric form. This is important. Remember, heme iron is directly absorbed inside the enterocyte, inside the cell lining your duodenum, but inorganic iron is present in ferric form. So what? So this. Inorganic iron is absorbed only in ferrous form, but the inorganic iron that you eat through plant products is in ferric form. So this ferric form of iron first needs to be converted to ferrous form, and then this ferrous form is taken in by the enterocyte. So there is an extra step required for the absorption of inorganic iron. That is why heme iron obtained from animal product gets absorbed much more faster than the inorganic iron obtained from plant product. Okay, again. So I said that there are two types of iron. There's your heme iron, which is obtained from animal product, and then there's your non-heme iron, which is also called inorganic iron, which is obtained from plant product. Your heme iron I'm representing here with the help of color yellow, and I'm representing the inorganic iron which is present in ferric form with color red, and the inorganic iron present in ferrous form with color blue. So once you have taken in animal product, you have heme iron from animal product. Once you have taken in plant product, you have inorganic iron in ferric form from plant product. Now, heme iron, it reaches the duodenum. In the duodenum, there are enterocyte cells or the cells of the intestine. Heme iron is taken directly into the enterocyte cell with no extra step required. Okay, but inorganic iron, which is present in ferric form, first needs to be converted to ferrous form. First needs to be converted to blue, this blue thing, ferrous form, and only then it is taken in by the enterocyte or the epithelial cell of your gut. Only then. So in order to convert ferric to ferrous, what should take place? See, there's your 3 plus oxidation number, here's your 2 plus oxidation number. So the oxidation number reduces from 3 plus to 2 plus, or reduction takes place. So ferric needs to be reduced to ferrous. This can be done either with the help of reducing agent or some enzymes which helps in reduction. So there are two ways. First, within the stomach, you have hydrochloric acid, which is a pretty strong reducing agent. So this hydrochloric acid, it reduces the ferric inorganic iron into ferrous inorganic iron. However, there are still ferric iron remaining. So all these iron, they reach the upper part of the intestine or duodenum. In the duodenum, you have heme iron, the ferric inorganic iron, as well as the ferrous inorganic iron. So the remaining ferric inorganic iron is reduced with the help of reductase enzyme. This reductase enzyme is present in the inner wall of the duodenum. So there's the reductase enzyme. This reductase enzyme, it reduces ferric into ferrous. And then this ferrous form is taken in by the enterocyte. Ferrous form is taken in by the enterocyte. One last time. Two types of iron, heme iron and inorganic iron. Heme iron is taken directly into the enterocyte without any extra step. Inorganic iron present in ferric form is first converted into ferrous form by two ways. Number one, with the help of hydrochloric acid present in the stomach. Number two, with the help of reductase enzyme present in the inner wall of the duodenum. And then finally, this ferrous form is taken in by the enterocyte of your duodenum. Okay. Once ferrous form is taken in, this ferrous form is then sent to the other side of the duodenum. After ferrous form reaches the other side of the duodenum, now this iron needs to be transported through blood to different parts of the body. However, for transportation, we again require the ferric form, not the ferrous form. The whole purpose of converting ferric form to ferrous form was only for this much step. For taking iron from one side of the duodenum, from inside the duodenum to outside the duodenum. Only for this much step, iron had first to be converted, inorganic iron had first to be converted into ferrous form. But once this ferrous form is sent to the other side of the duodenum, it again has to be converted to ferric form for the sake of transportation. So to convert ferrous into ferric, what should take place? Oxidation should take place. What type of enzyme do you require? Oxidase enzyme you should require. So you have oxidase enzyme outside. This oxidase enzyme, it converts ferrous into ferric, and then this ferric is transported through your blood. Inside the blood you have something called transferrin. To this transferrin, at one time two ferric can combine, and then this transferrin, it transports the ferric ion to different parts of the body where they are either used, for example, in bone marrow for the process of erythropoiesis, for the process of formation of hemoglobin, for the formation of heme. This ferric iron is utilized, and the extra iron present in blood, it is stored in the liver in the form of peritin. If there is too much iron, it is stored in the form of hemosiderin. Okay, now that you know the basics, let's look at the same thing in much more detail as per the diagram given in Robbins. So what I'm going to do is take this enterocyte right here and zoom into it. So this is what it looks like. It looks complicated, but trust me, I'll make it really easy for you. Just follow me. First, you have your enterocyte. What is enterocyte? It is the epithelial cell making the inner lining of your intestine. There's your enterocyte, the epithelial cell of your gut. So here I have taken enterocyte from duodenum. Here's the lumen and here's the blood. So there's the lumen, there's the enterocyte, and then there's the blood. Here's the lumen, here's the enterocyte, and here's the blood. Now this enterocyte has two surfaces. One surface is facing the lumen, which is called luminal surface, and the other surface is at the base or basolateral surface. So I've taken the same cell, flipped it, and we have it right here. So we have the luminal surface which is facing the lumen, and we have the basolateral surface or the basolateral side which is present at the base of the gut. Okay, so these are the two surfaces. Now let's look at the story of iron absorption. So I said that when you take in iron, you can take two different forms of iron. Number one is the iron obtained from animal product, which I have shown in color yellow. This is the heme iron. Number two is the iron that you can take from plant product, which is the non-heme or inorganic iron. Heme iron present in yellow does not go through any extra step. It is directly absorbed into the enterocyte with the help of a transporter. Since this transporter is for heme iron, it is called heme transporter. Simple. So here's the lumen. In the lumen, there's your heme iron. On the luminal side of the enterocyte, there's your transporter for the heme iron called the heme transporter, which allows for the entry of heme iron directly into the enterocyte without any extra step. But for the inorganic iron obtained from plant product, it is present in ferric form. First, this ferric form is reduced to ferrous form. This is done with the help of reductase enzyme present on the luminal side. This reductase enzyme is present on the luminal side of duodenum. That is why it is called duodenal cytochrome B. So duodenal cytochrome B, it reduces ferric to ferrous. One ferric gets converted to ferrous. Now this ferrous can be taken into the enterocyte. Why should this ferric be converted to ferrous? The reason being, there is a transporter present right here for metallic ions. Which type of metallic ions? Divalent metallic ions. So this transporter allows for the entry of divalent metallic ions into the enterocyte like Zn2+, Cu2+, and Fe2+. And that is why Fe3+ had to be first converted into Fe2+ so that it could pass through the divalent metallic transporter and reach inside the enterocyte. Okay. So after all that, you finally have all the ferric ions inside the enterocyte. Heme iron directly taken in with the help of heme transporter. Ferric iron first had to be converted to ferrous with the help of reductase enzyme, and then it passed through the divalent metallic transporter. Now you have all the ferrous iron required inside the enterocyte. Now this ferrous iron should be taken to the other side of the duodenum, or should pass through the basolateral surface. So on the basolateral surface, there is a portal for ferrous iron called ferroportin 1. Portal for ferrous iron, ferroportin 1, which allows for this ferrous iron to reach the other side of the duodenum. Nice. Now we finally have all the iron present on the luminal side, or present in the lumen on the other side of the duodenum. But we have this iron in ferrous form because we required ferrous form to pass the enterocyte, right? But then iron gets transported in ferric form. So we convert ferrous form to ferric form, and this is done with the help of oxidase enzyme present on the basolateral side of the duodenum called hephaestin. So ferrous gets converted to ferric, and then it gets transported with the help of transferrin. One transferrin, two ferric can bind, and this gets transported to different parts of the body. In bone marrow, iron gets utilized for the formation of heme. In liver, excess iron gets stored in the form of ferritin. If there is a lot of iron, there is iron overload, then the storage form is hemosiderin. Okay, now let me show you the same thing in the diagram given in your Robbins. Wait, before that, one small thing. So finally, iron reaches your blood. Through blood, it is sent to different parts of the body where it gets utilized, and the excess gets stored. As the storage form of iron increases, what has happened? See, the blood is saturated with iron. The blood has enough iron. That is why the excess is being stored in the liver. That means the blood no longer requires more iron. It does not require more iron. So what should be done? This should be stopped. More absorption of iron, more entry of iron into the blood should be stopped. How is it done? So once the level of stored iron in the liver, that is ferritin, increases, the liver starts producing something called hepcidin. This hepcidin, it inhibits ferroportin. When ferroportin 1 gets inhibited, ferrous iron can't get to the other side of the duodenum. When ferrous iron can't get to the other side of the duodenum, this ferrous iron can't get converted to ferric and then reach the blood. So the absorption of ferrous iron or iron is reduced. What happens to the iron present within the enterocyte? This iron gets encircled by mucosal lining, and what we get is mucosal ferritin. So this is ferritin, iron stored in enterocyte, not the liver, inside the enterocyte. We get mucosal ferritin. So as time passes, the inner lining of the duodenum gets set off. It gets set off and it comes out in the form of poop. So similarly, along with the inner lining, enterocytes also get set off. Along with the enterocyte, these iron or mucosal ferritin, they also get set off and they get out of your body. Okay. Final revision. So here's the diagram. Your food iron, it's of two types. Heme iron obtained from animal product, non-heme iron obtained from plant product. Heme iron is directly absorbed into the enterocyte with the help of heme transporter without going through any extra step. Non-heme iron, which is present in ferric form, first needs to be oxidized in ferrous form with the help of oxidase enzyme, and then this ferrous form, it passes through the divalent metallic transporter and reaches inside the enterocyte. Now inside the enterocyte, we have all the ferrous ions. This ferrous ion, it needs to be sent to the other side of the duodenum. This is done with the help of a portal which is called ferroportin 1. Now finally we have ferrous ions on the other side of the duodenum. However, iron, it transports or it travels in the form of ferric iron. So first this ferrous needs to be oxidized to ferric. This is done with the help of oxidase enzyme called hephaestin. Inside the blood, ferric gets transported with the help of transferrin. To one transferrin, two ferric gets attached. Then this transferrin takes to different parts like bone marrow where heme production takes place, and the excess of iron is stored in liver in the form of ferritin. As the amount of iron increases, the blood has enough iron. Excess iron is stored in liver. Now in liver there is enough ferritin. The liver starts secreting hepcidin. This hepcidin, it inhibits ferroportin. As a result, more iron can't reach the blood. So iron absorption decreases. So this is how the absorption of iron is regulated by hepcidin released from liver. See, this is what happens. So let's say the amount of iron in the blood increases. Serum iron level increases. Serum iron level increases. As serum iron level increases, ferritin in the liver or the storage form of iron in the liver also increases. This is detected by the liver. Now the body does not require any more iron. So the liver sends more hepcidin. As a result, there is more inhibition of ferroportin. As a result, there is less absorption of iron. But then let's say there is less serum iron in your blood. Serum iron in your blood, it falls down. As a result, ferritin, which is stored form of iron in the liver, it falls down as well. As a result, this is detected by the liver, and the liver starts secreting less hepcidin. Hepcidin level falls down as well. As a result, there is less inhibition of ferroportin. Less or no inhibition of ferroportin. As a result, ferroportin is open and functional, and there is more absorption of iron. This is how hepcidin released from liver, it regulates the absorption of iron. Okay. So the iron that reaches the blood, it has two compartments. The iron that reaches the blood has two compartments. One is the functional compartment, which is obviously the useful iron. Iron being used for formation of hemoglobin, myoglobin, catalase enzyme, cytochrome. And then there is storage compartment. The excess iron gets stored in the form of ferritin. When there is a lot of iron overload, it gets stored in the form of hemosiderin. There are two places where iron gets stored. If iron is brought by transferrin, the iron is being brought by transferrin, this iron is stored in your liver, in the liver parenchyma cells. But then if iron is obtained from destruction of RBC. See, there's your red blood cell. This red blood cell dies after 120 days. What remains is the inner content of the red blood cell, which gets destroyed, and we get iron. This iron is then stored inside macrophages of liver, spleen, bone marrow, etc. And this is what we call the reticuloendothelial system. The reticuloendothelial system is composed of macrophages of different organs in your body like liver, spleen and bone marrow. Inside these macrophages, the iron obtained from destruction or death of RBC is stored. Okay, regulation of iron absorption. So iron reaches your blood. This iron gets used, and the excess gets stored in the liver in the form of ferritin. Fine. As iron level increases, the stored form also increases. As stored form increases, the level of ferritin increases. That means no longer more iron is required by the body. So we need to decrease the absorption. How does this take place? Ferritin level increases. Hepcidin released from the liver increases. Inhibition of ferroportin increases. Absorption decreases. Similarly, if there is less iron in blood, there is less stored form of iron in your liver, there is less ferritin, so the liver starts secreting less hepcidin, there is less or no inhibition of ferroportin, and there is more absorption of iron to bring iron back to its normal level. Okay, now as I said earlier, your inorganic iron, it is absorbed in porous form, not in ferric form. It is not absorbed in ferric form. So let's say you have taken inorganic iron. If this inorganic iron in your body is present more in ferrous form, more absorption will take place. If it is present more in ferric form, less absorption will take place. So factor of increasing absorption and factors decreasing absorption. What will increase absorption of inorganic iron? Obviously, ferrous form will increase absorption. More ferrous form, more absorption. What will decrease absorption? Ferric form, more ferric form, less absorption. So obviously, those environment that will maintain more ferrous form will increase the absorption of iron. And what will maintain more ferrous form? Reducing agent. What are reducing agent? Your acids. So more HCl in stomach, more ascorbic acid, amino acid. These acids they convert ferric form to ferrous form. They reduce ferric to ferrous form. More ferrous form, more absorption. On the other hand, if there is less acid or if there is alkaline form, then ferric will not be converted to ferrous. There will be more ferric and there will be less absorption. Substances like phytates, tannates and phosphates, they make chelates with iron, which decreases the absorption of iron as well. Another is iron deficiency. When there is deficiency of iron, there is less storage form of iron and more absorption. When there is iron overload, that is excess of iron in the blood, there is excess of stored iron in the liver, there is excess of ferritin and there is less absorption. Okay, now what are the various factors or causes of iron deficient anemia? Here's your tiny little mouth and then here's your gut. Iron is taken in, it reaches the gut and then it gets absorbed. So if there is less iron intake, or if there is less iron absorption, or if there is less wastage of iron due to bleeding, or if there is increased requirement of iron, these can all lead to deficiency of iron in human body. So first, if there is less intake of iron. Second, if the iron is taken in sufficiently but then it is not absorbed. Third, if the requirement of iron in the body increases, so you are not taking in enough iron. Fourth, you are losing blood. Along with blood, iron is also being lost. So iron intake reduces if a person is surviving in a poor economic status. So the person doesn't have money for balanced diet and there is lack of iron in his or her diet. Or if there is lack of availability of iron rich products in the market, that can result in decreased intake of iron. Second is impaired absorption. All these factors, they decrease iron absorption. Ferric form, that is lack of HCl, as a result ferric is not reduced to ferrous, or increased alkaline condition, as a result ferric is not converted to ferrous, or phytates, tannates and phosphates which make chelate with iron so that iron is not absorbed, or if there is too much iron in your body already, as a result absorption of iron does not take place. Either way, so these are the main three. First four. These reasons lead to decreased absorption of iron. Along with that, if there is problem in the gut itself, for example, if there is chronic diarrhea or steatorrhea or gastrectomy, how does gastrectomy lead to iron deficient anemia? See, so there's your stomach. Stomach contains HCl. HCl is required for the conversion of ferric into ferrous. Ferrous is then absorbed by the gut. If you take out the stomach and throw it away, what will happen? There is no more HCl. If there is no more HCl, you have achloridria. When there is achloridria, ferric is not converted to ferrous, absorption does not take place, there is impairment in absorption. Increased requirement during pregnancy, during post-menopausal state of women, and in growing children, the requirement of iron is more than the usual typical requirement. Chronic blood loss. If there is hookworm manifestation, hookworm will continuously suck blood and iron will be lost continuously. That can lead to iron deficient anemia. Then pathogenesis. There are altogether 3 different stages of iron deficient anemia. Stage 1, 2 and 3. First stage. In first stage, in your blood, serum iron level is supposed to go down due to lack of iron in your body. However, serum iron level, it does not go down, or you do not suffer from anemia. The reason being, there is iron stored in your liver. When the iron level, when there is less absorption of iron in the body, this is detected by the liver, and the liver starts throwing away the ferritin reserve. As a result, the iron level in the blood is maintained. The stored iron in the liver goes down, but then this compensates for the iron level in the blood, and the iron level in the blood remains the same again. So what happens initially? Initially, let's say there is less absorption of iron. So the iron level in the blood is supposed to go down. However, there is stored iron in the liver. So the liver start giving away this stored iron to the blood. As a result, the level of iron in the blood is maintained, but then the storage iron, it reduces. This stage is called storage iron depletion. Why? Because there is depletion in storage iron, but then the iron level in the blood remains the same. Serum iron is normal. Transferrin is dependent on serum iron. When there is serum iron is high, transferrin is high. Serum iron is low, transferrin is low. Serum iron is normal, transferrin is normal. So since serum iron is normal, transferrin is normal as well. TIBC is total iron binding capacity. What does it mean? So there's a transferrin. To this one transferrin, two ferric irons, they can combine. Let's say there is no ferric iron in the blood. As a result, to this transferrin, nothing is combined. So there's gap here and there's gap here. That means the binding capacity of this transferrin has increased from 0 to 2. Let's say from 0 unit to 2 unit. So the binding capacity is high in first condition or second condition. Obviously, it is high in second condition because there are 2 empty spaces left. That is called total iron binding capacity. So initially it's normal, but then the stored ferritin level in the liver goes down in order to compensate for the serum iron and to maintain it as normal. Fine, that was the first stage. In the second stage, what happens is that now deficiency in iron starts occurring, but then anemia doesn't occur yet. Anemia does not occur yet because the deficiency is seen in the process of erythropoiesis. So during erythropoiesis, what happens? There's your stem cell. From this stem cell, myeloid progenitor cell. From this erythroid series, and then finally erythrocyte is formed. Or basically there is a series of cells that finally lead to the formation of erythrocyte. This series of cell, the cytoplasm contains hemoglobin. Now that there is deficit in iron, these cytoplasm, they become deficit of hemoglobin as well. But then the erythrocyte is yet not formed. Erythrocyte, anemic erythrocyte or iron deficit erythrocyte is yet not formed. The effect is seen in erythropoiesis. The effective seen is erythropoiesis, not in RBC yet. So this is second stage where there is iron deficient erythropoiesis, where erythropoiesis is suffering from deficiency of iron, but then anemia has yet not occurred. So what happens here? Obviously serum iron level goes down because there is deficiency of iron. Since serum iron level goes down, transferrin also goes down. But then we have transferrin with empty spaces because iron is not there. So total iron binding capacity increases. Ferritin obviously remains low. Okay. In third stage, finally, the effect of deficiency of iron, which was seen in erythropoiesis, is finally seen in the red blood cell. That is now red blood cell with less hemoglobin concentration is formed. And these red blood cells, they are smaller in size, microcytic, and the peripheral red is less than 2/3. The central pellar is more than 1/3. So hypochromic. You get microcytic hypochromic anemia. This is stage 3 or frank iron deficiency anemia. So that's the pathogenesis of anemia. What's the series? First, the iron absorption is less, so the level of iron in blood is supposed to be less, but then the liver has stored iron. This stored iron is given to blood. As a result, the blood iron level remains the same, but then the stored iron level goes down. This is stage 1 or storage iron depletion, where there is depletion in storage iron, but the serum iron level is maintained. Then what happens? Now the storage iron is gone. You have iron in the blood. This iron is utilized for erythropoiesis. However, since there is no more absorption of iron taking place, the iron for erythropoiesis is lacking. There is no more absorption. There is no more absorption, so there is less iron for erythropoiesis. No more absorption, less iron for erythropoiesis. As a result, erythropoiesis lacks iron. This is iron deficient erythropoiesis. Finally, erythrocytes are formed at the end of erythropoiesis, and these erythrocytes, they lack iron, they lack hemoglobin. So peripheral 2/3 is thinner, it is less than 2/3, and central pellar is larger. You get microcytic hypochromic red blood cells. Okay, now clinical features. You can mention all the general features of anemia, that is lethargy, the pallor, as well as old age problems related to heart. Then you have specific features of iron deficient anemia seen at 3 different places. Number 1, nails, where spooning takes place, which is also called koilonychia. Then tongue, where atrophy takes place and swelling takes place. This is called atrophic glossitis. And in the angle of the mouth, where chelosis or angular stomatitis takes place. There's a syndrome called Plummer-Vinson syndrome. It is a collection of clinical features. So in Plummer-Vinson syndrome, collection of clinical features due to deficiency of iron takes place. So there's a woman of age 40 to 45 post-menopause suffering from iron deficiency. See, I said earlier that one of the causes of iron deficiency anemia is increased requirement. There is more requirement of iron by the body. As a result, the requirement is not fulfilled by the regular intake of iron. The normal intake of iron is not enough. The normal intake is not enough. And this is seen in postmenopausal women as well. So what happens after menopause is the requirement of iron increases. As a result, the iron demand of the body may not be fulfilled in women, and she might suffer from iron deficient anemia. Along with iron deficient anemia, some other clinical features are also seen, and this forms the Plummer-Vinson syndrome. Like what? So there's the upper esophagus, lower esophagus, and stomach. In the upper esophagus, wave is formed. Due to this wave, swallowing of solid food becomes difficult. So esophageal wave formation takes place and swallowing becomes difficult or dysphagia. This triad of clinical feature marks Plummer-Vinson syndrome. So there is deficiency of iron leading to iron deficient anemia. There is formation of wave in the upper esophagus, so esophageal wave, due to which there is difficulty in swallowing solid food, so there is dysphagia. Along with that, your typical features of iron deficient anemia like chelosis and atrophic glossitis. Chelosis and glossitis is also seen. The syndrome is also precancerous because it can lead to cancer of tongue, hypopharynx, as well as esophagus. One small concept. So this thing that was formed inside the esophagus is wave, but if on the outer wall of the esophagus a swelling occurs, or outer wall of any part of the gut swelling occurs, that's a diverticulum. Okay. Lab diagnosis. Number 6. Lab diagnosis. So under lab diagnosis, there are 3 different findings for all sorts of anemia: blood finding, bone marrow finding, and biochemical finding. So you take a person suspected of anemia, you draw blood, make a blood smear on a slide, observe it under a microscope, you will find these. You take the blood sample and then perform CBC, you will find these. You take the bone marrow, check for cellularity, erythropoiesis, and marrow iron, you will find these. And you take the serum of the person and perform biochemical test, you will find these. First, blood findings. So under a microscope, upon observing the red blood cells of iron deficient anemia, you will find that the size of the red blood cell is smaller than small lymphocyte, microcytic. The peripheral red is less than 2/3, hypochromic. The cells are of different sizes, anisocytosis. The cells are of different shapes, poikilocytosis. The cells are ring-like in structure, ring or pessary cells. Again, so the cell is smaller, microcytic. The peripheral red is less than the central pellar or hypochromic. Cells of different sizes, anisocytosis, and cells of different shapes, poikilocytosis. Then you have RBC indices. All RBC indices, they fall down. There is deficiency of iron, so obviously hemoglobin goes down. The mean corpuscular hemoglobin goes down, and the mean corpuscular hemoglobin concentration also goes down. There is decrease in RBC production, so there is decrease in packed cell volume as well as decrease in mean corpuscular volume. Then there is bone marrow finding. In bone marrow finding, first cellularity. See, the production of RBC has decreased. The number of RBC has decreased. So to compensate for the decrease in production of RBC, hyperplasia takes place in the bone marrow. So during formation of RBC, what happens? There's your stem cell. From this stem cell, myeloid progenitor cell is formed. Then you have your erythroid series. Which contains a series of cells, and finally nucleus comes out, reticulocyte is formed, and RBC is formed. So due to decrease in production of RBC, there is increase in myeloid progenitor, due to decrease in number of RBC, there is increase in number of erythroid cells. To compensate for the decrease in number of RBC. See, RBC number is decreased, so the body makes more erythroid cells to increase RBC. This is a compensatory mechanism. As a result, what happens? Myeloid by erythroid ratio goes down. Why? See, myeloid number remains the same, but erythroid number, it increases. So same by increase, the ratio is decrease. This is more, this increases, so the ratio decreases. Myeloid by erythroid ratio decreases. Erythropoiesis. Cytoplasm lags behind nuclear maturation. Why? So normally nucleus matures, along with it cytoplasm matures. But in iron deficient anemia, there is lack of iron, there is lack of heme, there is less production of hemoglobin, so cytoplasm lags behind. Cytoplasm is yet to mature, but the nucleus has already gone front. The maturation level of nucleus has already gone front. So this nucleus reaches this level of maturation, but the cytoplasm here is still the same as cytoplasm here. So the maturation of cytoplasm is lagging behind. Then marrow iron. Since there is decrease in level of iron, obviously the iron stored in the bone marrow also decreases. Iron in bone marrow is detected with the help of a typical special stain called Prussian blue stain, which stains iron blue in color. Since there is decrease in iron level, there is also decrease in Prussian blue stain. Let's look here. So this is your normal iron store in bone marrow. This is your reduced iron store in bone marrow. You can see lots of Prussian blue stain. You can see scanty Prussian blue stain. Finally, biochemical findings, the same stuff that I explained earlier. In case of pathogenesis. These are the biochemical findings that you are going to get. Obviously, serum iron is going to go down. When serum iron falls down, transferrin falls down. Transferrin, they are empty. So total iron binding capacity increases. The stored iron in the liver goes down. So ferritin goes down. Treatment. So iron deficiency anemia can cause due to some other disorder. For example, in case of chronic diarrhea, or maybe there is acute blood loss during menstruation, or maybe due to piles. So due to these reasons, there is loss of blood. When there is loss of blood, there is loss of iron, and this leads to iron deficient anemia. So first we need to get rid of these disorders in order to cure iron deficient anemia. But then if anemia is caused due to actual deficiency in iron, like deficiency in intake of iron or maybe absorption of iron, then we can perform either oral therapy by giving salts of ferrous, Fe2 plus salts, because Fe2 plus gets absorbed easily, or you can also give iron dextran by IV route. The second type of anemia is megaloblastic anemia. In megaloblastic anemia, you are going to see some megastuffs, basically cells that are going to be larger than their normal size. So where exactly is megaloblastic anemia in this classification, pathophysiological classification? Earlier in the video, we saw a type of anemia where there was decrease in production of red blood cell or defect in production of red blood cell or impaired production of red blood cell due to defect in cytoplasm. Within cytoplasm, you have hemoglobin, which contains heme part and globin part. There was defect in the heme part due to lack of iron, causing what type of anemia? Iron deficiency anemia. But now, instead of cytoplasmic defect, we are going to have nuclear defect. And this nuclear defect leads to decreased production of RBC. And this is seen in megaloblastic anemia. In short, this is what happens in megaloblastic anemia. So, DNA is composed of adenine, thymine, guanine, and cytosine. Thymine is formed from uracil. Basically, there is a uracil containing molecule which gets converted to thymine containing molecule, and then this thymine containing molecule is utilized for the formation of DNA. However, for the conversion of this uracil containing molecule into thymine containing molecule, two stuffs are required. Number one, folic acid, and number two, vitamin B12. If there is deficiency of any one of them, either folic acid or vitamin B12 or both, uracil will not get converted into thymine. As a result, DNA synthesis will not take place, leading to nuclear defect, leading to decreased production of RBC. This is what happens in megaloblastic anemia. Okay, so finally, let's get into the anemia. Starting off with introduction. So in megaloblastic anemia, there is impaired DNA synthesis due to deficiency of vitamin B12 and folic acid. In order to understand how exactly DNA synthesis is impaired, first we need to understand how exactly vitamin B12 and folic acid are responsible for the formation of DNA. Basically, their metabolism. Starting off with absorption. So there's a huge process taking place for the absorption of vitamin B12. However, I'm not going to get into the detail. All I want you to know is that for the absorption of vitamin B12, you require intrinsic factor. So vitamin B12, it's bound to intrinsic factor, and then with the help of the intrinsic factor, it gets absorbed in the intestine. Let's say due to some reason, intrinsic factor production does not take place. In that case, vitamin B12 will not get absorbed through your intestine. Who is responsible for the production of intrinsic factor? The parietal cells present in the stomach. If you get rid of the stomach, let's say in case of gastrectomy, you cut the stomach and remove it. In that case, also there won't be parietal cell, there won't be intrinsic factor, and absorption of vitamin B12 will not take place. Or let's say the parietal cells, they become defective. As a result, production of intrinsic factor will not take place. In that case as well, vitamin B12 will not get absorbed, leading to defective production of RBC. Okay, here's the absorption of folic acid, you can see on your own. But let's get into the main part or the main story, and that is the involvement of vitamin B12 and folic acid in the production of DNA, in DNA synthesis. See, as I said earlier, first you have uracil containing molecule that's converted into thymine containing molecule with the help of folic acid and vitamin B12, and then this thymine containing molecule is utilized in the formation of DNA, right? That's exactly what's happening here. You have this uracil containing molecule getting converted into thymine containing molecule, and then this molecule is utilized in the process of DNA. in the formation of DNA. And two things are required, folic acid and vitamin B12. So this molecule right here is called deoxyuridylate monophosphate. This is deoxythymidylate monophosphate, and then finally DNA. For the conversion of DUMP into DTMP, folic acid is required. What happens? So you take in folic acid through diet. So you get your dietary folic acid, which is dihydrofolic acid. See, folic acid is present in two forms. One containing two hydrogen group called dihydrofolic acid, and the other containing four hydrogen group called tetrahydrofolic acid. Your food contains dihydrofolic acid, which is converted to tetrahydrofolic acid. Since there is addition of hydrogen, reduction is taking place, so you require a reductase enzyme. This tetrahydrofolic acid gains a methylene group and gets converted to methylene tetrahydrofolic acid. This methylene tetrahydrofolic acid is responsible for the conversion of UMP into TMP. Once methylene tetrahydrofolic acid converts DUMP into DTMP, it itself gets converted into dihydrofolic acid. This dihydrofolic acid is reutilized as it gets reduced into THF again. So this is where folic acid is used. The question is, where exactly does vitamin B12 come into action? So I said methylene THF is responsible for the conversion of UMP into TMP. But then for the formation of methylene THF from THF, you require vitamin B12. This is where vitamin B12 comes into action. Let's say you take less vitamin B12. As a result, there is less vitamin B12 in your body. Or maybe you take enough vitamin B12, but the absorption of vitamin B12 is impaired due to lack of intrinsic factor. Basically, there is no vitamin B12 in your body. Then what happens? THF will not get converted to methylene THF. As a result, this THF will get trapped at this process right here. It won't be able to move forward from this process. THF will get trapped, folate will get trapped, and this is what we call folate trap. Why does folate trap happen? It happens due to lack of vitamin B12 in the body, leading to what? Leading to decreased DNA or impaired DNA formation. All right, now etiology. So be it deficiency of vitamin B12 or be it deficiency of folic acid in your body, there are mainly three reasons behind it. Number one, due to decreased intake. Number two, due to impaired absorption. And number three, due to increased requirement. So one important thing in intake is that alcoholism leads to folic acid deficiency. Remember, alcoholism leads to folic acid deficiency. Other reasons are simple. Inadequate diet will lead to the deficiency. Veganism will lead to the deficiency. Infants, growing children can be deficient of vitamin B12 and folic acid. Then there's impaired absorption. For vitamin B12, what's required for absorption? Intrinsic factor is required for absorption. So if there is deficiency of intrinsic factor, vitamin B12 will not get absorbed and we will have deficiency of vitamin B12. There are two ways intrinsic factor can go deficient. Number one, if your parietal cells, they become defective, intrinsic factor is not released, and this leads to anemia called pernicious anemia. Pernicious anemia is nothing but a type of megaloblastic anemia occurring due to vitamin B12 deficiency due to deficiency of intrinsic factor. Simple. Second, gastrectomy. If you remove the stomach itself, along with the stomach gets removed the parietal cells. As a result, intrinsic factor will not be produced. There will be no intrinsic factor. Vitamin B12 will not be absorbed. Second is fish tapeworm infestation. If there is fish tapeworm infestation, then there is competition between the tapeworm and your body for the intake of vitamin B12, leading to deficiency in vitamin B12 for your body. Chronic pancreatitis. Chronic pancreatitis because during the absorption of vitamin B12, alkaline medium is required right here for the splitting of a certain complex, which you will know if you read this flowchart itself. And then intestinal diseases. As for folic acid deficiency, simple, if there is malabsorption, folic acid will not be absorbed, or if there are intestinal diseases, then folic acid absorption will not take place. If there is bacterial growth in the intestine, which can lead to inflammation of the intestine, in that case also absorption of vitamin B12 and folic acid can be impaired. Finally, increased requirement during pregnancy, during infancy, or during disseminated cancers. The requirement of vitamin B12 and folic acid is greater than the usual requirement. As a result, they might go lacking if not taken in enough amount in your diet. There can be other reasons behind folic acid deficiency. For example, if you take drugs that inhibit the metabolism of folic acid like methotrexate, phenobarbital, or phenytoin, you can see right here. See, if folic acid is deficient or if vitamin B12 is deficient, UMP will not be converted to TMP and DNA production will not take place. Now, folic acid can go deficient due to reduced intake, due to decreased intake, or folic acid may not be absorbed in your intestine due to malabsorption or due to intestinal diseases, or there might be drugs acting that inhibit DHF reductase. As a result, DHF will not get converted into THF and we require THF for this process to take place. Or you can have deficiency of vitamin B12. As a result, THF will not get converted to methylene THF and this process will not take place. UMP will not be converted to TMP. Now, let's look at the pathogenesis. So as I said earlier, in megaloblastic anemia, due to lack of vitamin B12 or due to lack of folic acid, UMP is not converted to TMP. As a result, impaired DNA synthesis takes place. Due to impaired DNA synthesis, DNA maturation lags behind cytoplasm maturation. See, during the process of erythropoiesis, the cells, they go through multiple stages. As they go through multiple stages, nucleus and cytoplasm, they mature side by side. Nucleus matures, cytoplasm matures, nucleus matures, cytoplasm matures, nucleus matures, cytoplasm matures, nucleus matures, cytoplasm matures, nucleus is ejected out, and then you have your RBC. In case of iron deficient anemia, due to deficiency of iron, the cytoplasm maturation was impaired. As a result, cytoplasm was lagging behind. Nucleus went forward, but cytoplasm is still to catch up. So the maturity of cytoplasm was lagging behind the maturity of nucleus. However, in megaloblastic anemia, there is impaired DNA synthesis or defective nucleus. As a result, it is the nucleus that lags behind cytoplasm. Cytoplasm maturation continues while the nucleus is still to mature. As a result, these cells that are formed called normoblast, they become larger in size. Finally, when nucleus is ejected out, the RBC that we get is also larger in size. So what happens? DNA maturation lags behind cytoplasm maturation. Normoblast, these precursor cells are your normoblast. These normoblasts are larger in size than usual due to greater amount of cytoplasm and due to lag in maturation of nucleus. As a result, normoblasts are no longer normoblasts, they are megaloblasts, large. Erythrocytes are no longer erythrocytes, they are macrocytes, they are large. However, hemoglobin synthesis is not affected. In iron deficiency anemia, there was lack of iron. As a result, heme production didn't take place and hemoglobin production was affected. However, in this case, there is no lack of iron, there is no problem with heme formation, and there is no problem with hemoglobin formation. So hemoglobin synthesis is normal. Hemoglobin synthesis is normal. But then overall, hemoglobin concentration decreases. The reason being, red cell count decreases. The number of RBC in your blood decreases. As a result, hemoglobin concentration of your blood decreases as well. I repeat, hemoglobin synthesis is not affected, but then hemoglobin concentration decreases due to decrease in red cell count. Finally, in this anemia, what you get are large RBCs, macrocytic RBCs with normal amount of normal hemoglobin concentration inside individual cell, or normochromic. You get macrocytic, normochromic RBCs. Why macrocytic? Because the mean corpuscular volume of RBC is more than normal, more than 100 femtoliter. Why normochromic? Because the peripheral red is 2/3 and the central pellar is 1/3, or the mean corpuscular hemoglobin concentration, that is the concentration of hemoglobin in one single RBC, is normal. So normochromic. The overall hemoglobin concentration decreases, but then the hemoglobin concentration inside single RBC remains same, so normochromic. But then the RBC count decreases, that is why hemoglobin concentration throughout the body decreases. Okay, clinical features. You have your general features like lethargy, weakness, muscle pain, in old age, angina, heart failure, intermittent claudication, pallor in conjunctiva, nail bed, skin, tongue, and palm. That's general. Along with that, you have specific clinical features due to vitamin B12 deficiency. Why? See, vitamin B12 is required for the formation of neuronal lipids, and neuronal lipids are what forms the myelin sheath of your neurons. So if there is lack of neuronal lipids, demyelination takes place, which leads to peripheral neuropathy. You can also see atrophic glossitis, where the tongue is red, smooth, and beefy. Okay. Then lab diagnosis. Same procedure to be followed. You look at 3 different findings: the blood findings, bone marrow findings, and biochemical findings. In blood finding, you take blood, you make the smear of the blood on the slide, and then observe it under the microscope. You take the sample of the blood and also carry out CBC, or complete blood count. These are the results that you will get. Upon observing the smear under the microscope, you will find that the red blood cells, they are larger than the small lymphocytes, so macrocytic. The peripheral red is more than the central pellar, so normochromic. The sizes of the cell are different, so anisocytosis. The shapes of the cells are different as well, so poikilocytosis. The cells, they are tear-shaped, asucosept, tear-shaped, so teardrop-shaped. Some of the cells, instead of being round, they are also spherical and large, or oval and large. Sorry, not spherical, oval and large, macroovalocytes. So these are the various types of RBCs that you can find. Then you have your various RBC indices. In RBC indices, the number of red cells, they decrease. Hemoglobin concentration throughout your body decreases. Since the cells are macrocytic, obviously the mean corpuscular volume is greater than normal. The mean corpuscular hemoglobin is greater than normal. Mean corpuscular hemoglobin concentration is normal. See, mean corpuscular hemoglobin concentration is equals to mean corpuscular hemoglobin by mean corpuscular volume. So for the ratio to be normal, if there is increase in MCV, there obviously has to be increase in MCH. Simple maths. Again, look at the part of the video containing RBC indices carefully for you to understand all of these points. So I said that there is defect in DNA and not in cytoplasm. So if there is defect in DNA or defect in nucleus, obviously it's not just gonna be RBCs that are affected, because these precursor cells of RBC, they contain nucleus. Defect in nucleus lead to your megaloblastic anemia. But then nucleus is also present in other cells like your WBCs and platelets. So obviously defects are going to seen in your WBCs and platelets as well. Like what? In platelets, you will find platelets of bizarre forms. And most important of all, the very first manifestation of megaloblastic anemia. Let's say a person suffers from megaloblastic anemia. The very first manifestation that is seen in the blood of that person is hypersegment neutrophil. Neutrophils, they usually have 3 to 4 lobes, right? But in hypersegment neutrophil, you are going to find more than 3 4 lobes, many lobes of nucleus inside the neutrophil. Then bone marrow finding. Cellularity increases because there is decrease in red cell, so compensatory hyperplasia takes place. Erythropoiesis, nucleus, it lags behind cytoplasm. Marrow iron, it is normal because there is nothing taking place with iron. Biochemical findings, everything related to iron remains normal because iron is not affected. Okay, so in this smears observed under a microscope, you can see hypersegmented neutrophil, which is the very first manifestation of megaloblastic anemia. And then there are 3 characteristics. These 3 characteristics, they show defective erythropoiesis is going on. So these are 3 RBCs with 3 different characteristics that show that defective erythropoiesis is going on. So here's your Howell-Jolly body, here's your basophilic stippling, and here's your Cavort's ring. Let's zoom in. So first, the very first evidence of megaloblastic anemia is hypersegmented neutrophil. Hypersegmented neutrophil. We have evidences of defective erythropoiesis. These are erythrocyte, each of them with typical feature. You can see 8-shaped Cabot ring right here, many dots which are your basophilic stippling, and then Howell-Jolly body. You can see the various types of cells under microscopy right here. So this is your macro-ovalocyte, this is tear-shaped cell, and then this is your macrocyte. You can find cells of different sizes, so anisocytosis, and cells of different shapes, so poikilocytosis. There are various tests that is carried out in order to figure out or test or detect vitamin B12 deficiency and folic acid deficiency. But there is a special test which is responsible for finding, which helps you to find out the cause behind vitamin B12 deficiency. See, how can vitamin B12 deficiency take place? It can occur if there is decreased intake of vitamin B12. It can occur, let's say vitamin B12 you are taking sufficiently, but then there is impaired absorption. Absorption is not taking place properly. Now within absorption, there can be 2 possible reasons. Number 1, if there is no intrinsic factor, or number 2, because there is bacterial growth and inflammation in the intestine. So what is the reason behind vitamin B12 deficiency? That is found out with the help of this test called Schilling test. So this is your Schilling test. This is what happens in Schilling test. So again, why is Schilling test performed? It is performed to find out the cause behind vitamin B12 deficiency in your body. What could be the cause? Either decrease in intake of vitamin B12, or lack of intrinsic factor, or bacterial growth in intestine. So there are various stages of this step. By following each of these stages, you test whether there is less intake of vitamin B12 or not. Then in next stage, you test whether vitamin B12 absorption is deficient absorption is taking place due to deficiency of intrinsic factor or not. And in stage 3, you check whether defective absorption of vitamin B12 is taking place due to bacterial growth in intestine or not, one by one. So first, this is what you do. You take 2 different vitamin B12 supplement. 1 vitamin B12 supplement, 2 vitamin B12 supplement. First vitamin B12 supplement is given by intramuscular route, and this is not radioactive. The second vitamin B12 supplement is given by oral route, so you take an oral pill, and this is radioactive. Now in a normal person, this is what happens. So you get vitamin B12 by intramuscular route. Obviously, it reaches the blood much faster as compared to vitamin B12 given by oral route. So vitamin B12 through intramuscular route reaches your blood. From blood, it reaches your tissue and gets stored in the tissue. Once vitamin B12 gets stored in the tissue gets saturated. The tissues, they are full. Their stomach is full. Tissue is full of vitamin B12. They don't require or they can't take any more vitamin B12. So what happens to the oral radioactive vitamin B12? Obviously, tissue can't take this oral radioactive vitamin B12, so it gets excreted out through your kidney in the form of urine. So you take this urine sample and then test it. You check it. If the radioactive vitamin B12 is found in urine more than 8 to 10%, more than 8 to 10%, that means there is normal absorption. See, absorption had to be normal so that the oral radioactive vitamin B12 reached the blood. Yes or no? The oral vitamin B12 reached your gut. Now the gut absorbed the oral radioactive vitamin B12 and then it was excreted out of the kidney. If oral radioactive vitamin B12 was not absorbed through your gut, it would not have been excreted out of your kidney. And in that case, less than 8% would be present in the urine. This would signify that there is impaired absorption. So in first case, when there is normal absorption and the person has megaloblastic anemia along with peripheral neuropathy due to vitamin B12 deficiency, you can say that this person is having vitamin B12 deficiency due to less intake. In the second case, you have impaired absorption. Now, impaired absorption can be due to two reasons, either intrinsic factor deficiency or bacterial growth. First, in stage 2, we check for intrinsic factor deficiency. For that, you carry out the same process. You give vitamin B12 by intramuscular route, which is not radioactive. You give vitamin B12 by oral route, which is radioactive. Along with that, you also give oral intrinsic factor. So, if absorption deficiency is there due to intrinsic factor deficiency, what will happen? The intrinsic factor taken by oral route will allow for the absorption of the vitamin B12, right? Vitamin B12 taken by oral route. As a result, upon urinating, vitamin B12, the radioactive vitamin B12 will be present in the urine, 8 to 10% will be present in the urine. This shows that impaired absorption was taking place due to lack of intrinsic factor. But then let's say still, even after taking intrinsic factor, urine contains less than 8% of vitamin B12. That means the malabsorption was not taking place due to lack of intrinsic factor. It is taking place due to some other reason. So we carry out stage 3. In stage 3, intramuscular route vitamin B12 non-radioactive is given, oral route vitamin B12 radioactive is given, and this time you also give antibiotic or anti-inflammatory drug. So antibiotic, anti-inflammatory drug. So if malabsorption is taking place due to bacterial growth, what will happen? Antibiotic, anti-inflammatory drug will act on them, kill them, and temporarily heal the place. As a result, absorption of oral radioactive vitamin B12 will take place. It will get urinated out due to saturation of cell by intramuscular vitamin B12 in the urine. Upon testing, you'll find that 8 to 10%, not 80, 8 to 10% of urine is composed of radioactive vitamin B12. That means impaired absorption was due to bacterial manifestation. This is your Schilling test. By carrying test in stage 1, 2 and 3, you were able to figure out the reason behind vitamin B12 deficiency. From stage 1, you were able to find out the reason being less intake if there is normal absorption. In stage 2, you found out the reason being lack of intrinsic factor if the oral intrinsic factor worked, and in stage 3 we found out that the reason for malabsorption being bacteria if antibiotic and anti-inflammatory they worked. This right here is the summary of everything I just said. The table, you can look at the table. Till now we have already seen two different types of anemia. First was iron deficiency anemia. In iron deficiency anemia, there is deficiency of iron As a result, there is decrease in production of heme because heme is composed of iron. As a result, there is decrease in production of hemoglobin. As a result, cytoplasmic defect occurs in progenitor and stem cells of red blood cells. As a result, there is decreased production of red blood cells. Simple? Okay. Next we saw was megaloblastic anemia. In megaloblastic anemia, what happens is that, so for the conversion of uracil containing molecule into thymine containing molecule, we require vitamin B12 as well as folic acid. And this thymine is then utilized for the formation of DNA. In megaloblastic anemia, either due to deficiency of vitamin B12 or deficiency of folic acid or deficiency of both, this uracil containing molecule does not get converted into thymine containing molecule. As a result, DNA synthesis does not take place, leading to nuclear defect in stem cell and progenitor cell of erythrocytes. As a result, there is decreased production of erythrocytes or RBCs. Simple? Okay. Now we are going to look at hemolytic anemia. As the name suggests, in hemolytic anemia, hemolysis takes place. That is destruction of red blood cells. Hemolysis takes place. So anemia is occurring due to decrease in red blood cells, due to destruction of red blood cell or hemolysis of red blood cell. What happens or how exactly does red blood cell gets destroyed? So there's your healthy red blood cell. After 120 days, it gets destroyed in the reticuloendothelial system and there is release of bilirubin. When bilirubin gets deposited in your blood at a much higher level, it causes a disease called jaundice. So if an anemia is accompanied by jaundice, it is most likely hemolytic anemia. So remember, if you see a patient with anemia as well as jaundice, the type of anemia is most likely hemolytic anemia. Why? Because in hemolytic anemia, hemolysis of RBC takes place, which results in the release of bilirubin, and the deposition of bilirubin causes jaundice. Okay, now let's begin hemolytic anemia. First, introduction. In hemolytic anemia, hemolysis of RBC takes place. Destruction of RBC takes place at a much higher rate than normal. See, RBC normally gets destroyed after 120 days. However, in hemolytic anemia, RBC gets destroyed before 120 days. That means RBCs are getting destroyed faster, or there is higher rate of destruction of RBC, or premature destruction of RBC. RBCs are getting destroyed before it gets matured, before it hits the 120 days mark. All right. Now, in a normal human being, how does a normal RBC get destroyed? First, let's understand that so that we can get into the pathophysiology of this anemia. So, normally, you have your red blood cell. After 120 days, the red blood cell, it becomes old. This red blood cell then gets destroyed by the reticuloendothelial system. The reticuloendothelial system is formed by macrophages of various organs like liver, bone, and spleen. So the macrophages of liver, bone, and spleen, they form the reticuloendothelial system. What happens is that these macrophages, they engulf the RBC once RBC hits the 120 days mark. Then inside these macrophages, RBC hemoglobin gets broken down into its two components, heme and globin. Globin gets further broken down into amino acid, which is reused for the formation of protein. Now what about heme? Okay, so heme gets acted upon by enzymes present in the macrophage. There are two major enzymes. Enzyme number 1, heme oxygenase. Heme oxygenase breaks heme into iron, which is reused, and biliverdin. Then there is second enzyme called biliverdin reductase, which reduces biliverdin into unconjugate bilirubin. Due to the high deposition of bilirubin, high deposition of unconjugate bilirubin, jaundice may occur. This unconjugate bilirubin is then taken up by the liver where conjugation takes place, and finally it is excreted out. Again, let's look at this flowchart right here. So you have your red blood cell. Once it hits 120 days mark, It is engulfed or phagocytosed by the macrophage of reticular endothelial system. Once it enters the macrophage, it is acted upon by various enzymes. But first, the hemoglobin of the red blood cell, it gets dissociated into globin and heme. Globin gets broken down into amino acid, which is reused for the formation of protein. Heme, on the other hand, gets first acted upon by heme oxygenase, which breaks heme into iron, which is reused, and biliverdin. Biliverdin is again acted upon by biliverdin reductase present in the macrophage, which converts biliverdin into bilirubin. Now, this bilirubin is conjugated in the liver and then excreted out. So that was normal metabolism of your or normal destruction, normal physiology of or normal biochemistry of destruction of red blood cell. Now, what you need to know is how exactly do these red blood cells get destroyed in hemolytic anemia. This is how red blood cells, they get normally destroyed. But in hemolytic anemia, RBCs get destroyed before they even hit 120 days. There is premature destruction of RBCs. So how do these RBCs get destroyed prematurely? On the basis of that, on the basis of how they get destroyed, we have classified hemolytic anemia into various types. Let's look at it. So there are two reasons behind hemolysis. Number one, it could be hereditary or it could be acquired. Hereditary means by birth there is such a defect in the genetic makeup such that RBCs, they get destroyed. Acquired means after birth, as life goes on, certain changes occur or certain thing happen. As a result, RBC gets destroyed. So hereditary is due to genetic disorder. Acquired is after life or after birth. So even in hereditary, what do you have? You have your red blood cell. In red blood cell, there's the outer membrane of the red blood cell and the inner content of the red blood cell. So abnormality due to genetic makeup can occur either in the membrane of the red blood cell or in the inner content of the red blood cell. So there can be abnormality in RBC membrane as well as abnormality in RBC interior. Now, what is present inside RBC? You obviously have hemoglobin and you also have enzyme. So the defect can either be in enzyme or the defect can be in hemoglobin. First, abnormality in RBC membrane. So here's your RBC. A normal RBC is biconcave. However, you can have, due to genetic disorder, spherical RBC, which your body does not recognize and kills and destroys it. This is seen in hereditary spherocytosis. In hereditary spherocytosis, there is manufacture of spherical RBCs, which gets destroyed by your own body, leading to anemia. Then there's abnormality in RBC interior. Inside RBC, there can either be defect in enzyme or there can be defect in hemoglobin. So enzyme, you have G6PD enzyme. If there is deficiency of G6PD enzyme inside RBC, it leads to the destruction of RBC. Second is hemoglobin defect. Hemoglobin defect is also called hemoglobinopathy. Now, hemoglobin defect can occur in two ways. Either defect in the quality of hemoglobin or defect in the quantity of hemoglobin. For example, in sickle cell anemia, see, this is what a single hemoglobin structure looks like. There are 4 iron molecules. To these 4 iron molecules, there are single globin molecule to each of them. There are 2 alpha globin and 2 beta globin chain. Okay, so there's iron and then there's globin. There is heme. Again. So hemoglobin contains heme plus globin protein, right? The heme is the iron part. Globin protein contains alpha and beta globin chains. There are altogether 4 iron molecules, each of them associated with one globin protein. Out of these 4 globin proteins, 2 are alpha chain and 2 are beta chain. In case of sickle cell anemia, there is mutation in the beta chain. As a result, the quality not the quantity, the quality of the globin protein is affected. So there is hemoglobin defect due to qualitative defect. That is, there is defect in the quality of the globin protein leading to sickle cell anemia. In thalassemia, what happens is that either there is defect in the production of alpha chain or beta chain leading to quantitative defect of hemoglobin. So in thalassemia, quantitative defect is seen. So that was hereditary hemolytic anemias. What about acquired? So acquired are those acquired after birth. So there can be various reasons behind it. First, antibody. So your own body starts making antibodies against your own RBCs. That is autoimmune hemolytic anemia. Mechanical trauma. Let's say there's your blood vessel, there's your red blood cell, there's some kind of obstruction. This red blood cell strikes or collides with the obstruction and gets destroyed. So this is your mechanical hemolytic anemia due to mechanical trauma. Microangiopathic hemolytic anemia. Then there's your acquired RBC membrane abnormality, which includes P and H. Or it could be due to direct toxin effect. For example, in malaria, there is parasite within the RBC. The RBC gets broken with the release of hemozoin toxin. So this is how RBCs get destroyed in malaria or splenomegaly. So we saw the various causes of hemolysis or destruction of RBC. Now the question is, how exactly do these RBCs get destroyed? What happens after these RBCs get destroyed? And what are the various biochemical findings which are accompanied with the destruction of these RBCs? So here's the pathogenesis. So RBCs that get normally destroyed after 120 days. However, in hemolytic anemia, RBCs get destroyed before 120 days. That is, there is premature destruction of red blood cell. Now, the destruction of red blood cell can take place either within the blood vessel, that is intravascular hemolysis, or outside the blood vessel, which is extravascular hemolysis. There is intravascular hemolysis and extravascular hemolysis. In intravascular hemolysis, RBC destruction takes place inside the blood vessel. In extravascular hemolysis, RBC destruction takes place outside blood vessel in reticuloendothelial system. Reticuloendothelial system contains what? It contains macrophages of liver, bone, spleen. Okay, let's look at each of these hemolysis one by one. First, intravascular hemolysis. In intravascular hemolysis, there is your red blood cell in circulation. This red blood cell, it gets destroyed due to some reason. Maybe antibodies are formed against it, or maybe this red blood cell, it strikes against a thrombus present on the wall of the blood vessel. As a result, it ruptures. But somehow the red blood cell gets ruptures. After red blood cell gets ruptures, the content present within the red blood cell, it leaks out. And what is present inside a red blood cell? Enzymes and hemoglobin. So lactic acid dehydrogenase comes out. As a result, the level of lactic acid dehydrogenase in the blood increases. Lactic acid dehydrogenase level in the blood increases. Along with that, hemoglobin comes out. So the level of free hemoglobin in the blood increases as well. This condition is called hemoglobinemia. This free hemoglobin then binds with haptoglobin, which is present in the blood, which causes the excretion of haptoglobin. As a result, the level of haptoglobin in the blood decreases. Some of these hemoglobin, they reach by circulation to kidney. Inside kidney, it reaches inside the kidney, then it gets excreted out of the kidney through urine. So there is hemoglobin in urine, and this condition is called hemoglobinuria. Hemoglobin does not just get excreted in the form of hemoglobin. Some of it gets broken down in the form of broken down into iron. This iron is then stored in kidney, in the form of hemosiderin. This hemosiderin is then excreted out through urine. So urine containing hemosiderin is called hemosiderin-urea. So what are the various changes we see? We see that with the destruction of RBC, there is leakage of content inside the RBC. These include LDS. So the LDS level increases, free hemoglobin comes out, resulting in hemoglobinemia. Hemoglobin combines with haptoglobin, which causes the excretion of haptoglobin. As a result, the level of haptoglobin in the blood decreases. Some of these hemoglobin there is the kidney get excreted out through urine, resulting in hemoglobinuria. Some hemoglobin get broken down into iron. Iron is stored in the form of hemosiderin. Hemosiderin gets excreted out in the form of hemosiderin-urea. So you have elevation of LDH, you have hemoglobinemia, you have decreased haptoglobin, you have hemoglobinuria and hemosiderin-urea. However, even in intravascular hemolysis, even in intravascular hemolysis, what happens is that even though RBCs are destroyed, the destruction of RBC is taking place within the blood vessel. That's there. In intravascular RBC hemolysis, RBCs are getting destroyed within the blood vessel. However, hemoglobin, they can reach outside the blood vessel, like in kidney and even to reticuloendothelial system. So this hemoglobin gets taken up by reticuloendothelial system, and the exact same process like here takes place, That is, the hemoglobin gets broken into heme and globin. Globin is broken into amino acid, which is reused for the formation of protein. Heme is broken into iron and biliverdin. Iron is reused. Biliverdin is converted to bilirubin, and bilirubin excess amount can cause jaundice. However, since in intravascular hemolysis, only few amount of hemoglobin reaches reticuloendothelial system, there is slight increase in bilirubin, leading to slight jaundice, not extreme, not severe jaundice, but slight jaundice. Next is extravascular hemolysis. Extravascular hemolysis, extremely easy. Exactly what I have told you here, in case of normal physiology is what happens in extravascular hemolysis as well. Except the difference is, in normal physiology, in normal hemolysis, RBC gets destroyed after 120 days. But in extravascular hemolysis, that is hemolytic anemia, RBCs, they get hemolyzed, they get broken down prematurely. What happens? The RBC gets engulfed by the macrophage of reticuloendothelial system. Inside the macrophage, it has hemoglobin. Hemoglobin gets destroyed into globin, and hemoglobin is broken into amino acid, which is reused for the formation of protein. Heme is converted to biliverdin, then to bilirubin, and then this bilirubin is sent out. Now, since there is increased rate of destruction of RBC, there is increased level of unconjugate bilirubin in the blood as well. More RBCs are getting engulfed, more RBCs are getting destroyed, more heme is getting converted to biliverdin, more biliverdin is converted to unconjugated bilirubin, more unconjugated bilirubin is present in your blood. As a result, you have excess jaundice. If this process of hemolysis is taking place inside spleen, it can result in splenomegaly, but if it is taking in liver, then it can result in hepatomegaly. We are finally done with the basics of hemolytic anemia. So what is hemolytic anemia? It is a type of anemia where there is decrease in red cell mass due to the decrease in number of red cell due to the destruction of red blood cells. And this destruction of red blood cell is called hemolysis. If hemolysis takes place within the blood vessel, that's intravascular hemolysis. But if hemolysis takes place outside the blood vessel in reticuloendothelial system, then that's extravascular hemolysis. Fine. Now there are various causes of hemolysis. That is, how exactly does hemolysis or the destruction, premature death of RBC even occur? There are various causes, and based on that, we have classified hemolytic anemia into various categories. So majorly, there are two types of hemolytic anemia: hereditary and acquired. In hereditary hemolytic anemia, the cause of hemolysis is by birth due to genetic disorder. In acquired hemolytic anemia, the cause of hemolysis of RBC is acquired later on in life. So hereditary hemolytic anemia is due to some disorder specially related to genetics which occurs by birth itself. Acquired hemolytic anemia is where the reason behind the hemolysis of RBC is acquired later on in life after birth, not by birth. Within hereditary also, the genetic disorder can lead to abnormality of the red blood cell. This abnormality can either occur to the membrane of the red blood cell or the internal content of the red blood cell. What are the internal content? The internal content of red blood cell are obviously your enzymes and hemoglobin. So the defect can either occur to enzyme or hemoglobin. If defect occurs to hemoglobin, that is what we call hemoglobinopathy. So what is hemoglobinopathy? Hemoglobinopathy is a pathological condition which leads to hemolytic anemia due to defect in the hemoglobin of the RBC. Again, there is your red blood cell. The defect can be seen either to the membrane of the red blood cell or to the internal content of the red blood cell. The internal content includes enzymes and hemoglobin. The defect can be seen in hemoglobin. If the defect is seen in hemoglobin leading to hemolytic anemia, then that is called hemoglobinopathy. Now, even within hemoglobin, the defect can occur either due to abnormality in the structure, that is qualitative hemoglobinopathy, or amount, that is quantitative hemoglobinopathy. That is, you have hemoglobin. So either there is some problem with structure or some problem with amount of hemoglobin inside the red blood cell. For example, sickle cell anemia. In sickle cell anemia, there is defect in the structure of the globin protein of hemoglobin. So that's qualitative hemoglobinopathy. Thalassemia. In thalassemia, there is reduced production of globin protein in hemoglobin of RBC. So that's quantitative hemoglobinopathy. So hemoglobinopathies, what are they? They are pathological conditions where hemolytic anemia or hemolysis of RBC is seen due to the defect. Which kind of defect? Hereditary defect, by birth defect in the hemoglobin of RBC. Now, the defect can be either related to the quality of hemoglobin or quantity of hemoglobin. That is, either the structure of hemoglobin is altered or the amount of hemoglobin is altered. If the structure of hemoglobin is altered or defective, then that is qualitative hemoglobinopathy. But if amount of hemoglobin is altered, then that is quantitative hemoglobinopathy. So qualitative hemoglobinopathy is where there is structural abnormality of hemoglobin, and quantitative hemoglobinopathy is where there is decreased synthesis of globin chain. Example, sickle cell anemia for qualitative and thalassemia for quantitative. Alright, now let's get into the two different types of hemoglobinopathy. The very first is sickle cell anemia. Introduction. Sickle cell anemia is qualitative hemoglobinopathy. In hemoglobinopathy, what is there? There is defect in the hemoglobin of RBC. What does hemoglobin of a typical RBC look like? So hemoglobin contains heme and globin protein. There are altogether 4 heme molecules that contain iron, and there are altogether 4 globin proteins, each associated with individual heme molecule. Out of 4 globin proteins, there are 2 alpha chain and 2 beta chain. If in the structure of the globin protein abnormality occurs, then qualitatively the hemoglobin is altered. Quality of the hemoglobin is altered, not amount, not quantitative. So in sickle cell anemia, it is the quality of hemoglobin due to alteration in structure of the globin protein, we get qualitative hemoglobinopathy. Okay, another thing, sickle cell anemia. So where exactly does this qualitative abnormality take place? So as I said earlier, hemoglobin contains 4 heme molecule and 4 globin molecules. Out of 4 globin molecules, 2 are alpha chains and 2 are beta chain. It is in the structure of beta chain globin protein where the alteration occurs and hemoglobinopathy takes place. Beta chain structure. What type of disease is it? It is an autosomal recessive disorder. Autosomal, that means the gene that is responsible for this anemia is present on an autosome, which is a non-sex chromosome. Recessive, that means both the alleles of the allelic pair, one is obtained from father, one is obtained from mother. You have homologous pair, right? Homologous pair of chromosome, one chromosome obtained from father, one chromosome obtained from mother. This maternal contains one allele, paternal contains one allele. Both these alleles obtained from two parents need to be recessive so that this disorder is reflected or this disorder is expressed in your body. So what are the two possible alleles? The two possible variants of alleles are HbA, where the hemoglobin is not affected. This is the allele that codes for normal hemoglobin. And HbS, this is your mutated allele. This allele codes for sickle cell hemoglobin. Okay, so we have the two alleles. Now, what are the possible combinations of these two alleles? We can have HbA, HbS. This is heterozygous, where HbA is dominant and HbS is recessive. So, this allele, HbA, it codes for normal hemoglobin, and HbS, this protein codes for sickle cell hemoglobin. So, there is combination of both normal RBC and sickle cell RBC. This is called sickle cell trait, where the person can lead a normal life. Second combination is HbS, HbS. Here, there is homozygous, recessive or dominant. Since the mutated is the recessive trait, so this is homozygous recessive. Here, HbS codes for sickle cell hemoglobin. Another HbS also codes for sickle cell hemoglobin. As a result, 100% of the red blood cells are sickle celled. So here the person suffers from sickle cell anemia. Finally, along with sickle cell allele, another allele may be present, which is the reason behind some other hemoglobinopathy. For example, HbS and Hb alpha. Here HbS codes for sickle cell RBCs, while Hb alpha codes for alpha-thalassemia RBCs. So there is combination of two different hemoglobinopathies, sickle cell alpha-thalassemia. There is double heterozygous. I'm going to make your concept even clearer with the help of this simple diagram right here. So there's your father and then there's your mother. This father has sickle cell trait, that is one of the allele is normal while the other allele codes for sickle cell RBCs. Mother also has sickle cell trait, that is one allele is normal and the other allele is has the sickle gene. So let's say both of them ended up having children. What are the possible combinations of these two genes that can be expressed in their children? The first one, you know that an offspring gains 50% of their chromosome from father and half of their chromosomes from mother. So this child right here gets one normal allele from father and another normal allele from mother. As a result, the child does not have any sickle cell in his or her body. Now here is another case, another offspring. This offspring gets normal allele from father, but then sickle cell allele from mother. As a result, one allele codes for normal cells, while the other allele codes for sickle cells. So this child right here has sickle cell trait. Third possibility, the child might get one sickle gene from father and another sickle gene from mother. As a result, 100% of the gene codes for sickle cells or sickle cell hemoglobin, and the child suffers from sickle cell disease. Again, in this case, I'm showing you the double heterozygous condition. So this person right here gains 50% of its gene from this person and 50% from this person. So this person has a chromosome with allele coding for beta-thalassemia trait, and this person has a chromosome with allele coding for sickle cell. So the offspring might get both the chromosomes, that is the chromosome coding for beta-thalassemia and the chromosome coding for sickle cell. So now the person has both beta-thalassemia as well as sickle cell. Okay, again, so this is a simple representation of everything that I have said so far. So one chromosome from father, one chromosome from mother. So one chromosome obtained from father can be normal, another chromosome obtained from mother can be normal. So both chromosomes are normal, both alleles are normal, they code for normal RBCs. This is homozygous dominant. Another, one chromosome normal obtained from father, one chromosome mutated obtained from mother. So the normal chromosome has normal gene, the mutated chromosome has the sickle gene. So the normal chromosome, it codes for protein that makes normal RBC. The mutated chromosome with sickle cell gene codes for protein that makes sickle cell RBCs. So here certain RBCs are normal and certain RBCs are sickle celled. This is sickle cell trait. Third condition, one chromosome from father which is also mutated and another chromosome from mother which is also mutated. Both mutated chromosomes, they contain sickle cell gene. So both these chromosomes code for proteins for the formation of sickle cells. So the person suffers from sickle cell anemia because 100% of the RBCs present in the blood is sickle celled. And fourth condition, one chromosome from father which codes for alpha-thalassemia and another chromosome from mother which codes for sickle cell. As a result, both alpha-thalassemia and sickle cell diseases are seen in the blood of this person. Okay, now let's look at the normal types of hemoglobin so that we can understand the abnormality in the hemoglobin once we get into the pathophysiology of sickle cell anemia. So there are three different normal types of hemoglobin. As I said earlier, hemoglobin contains globin protein, right? And there are altogether 4 globin proteins, out of which 2 of them are alpha chains and the rest 2 are mostly beta chains. So you have 2 alpha chain and 2 beta chain. This is the hemoglobin A, found 95 to 98% in human body. But instead of beta chain, there might also be gamma chain, alpha, beta, gamma chain. This forms hemoglobin F, which is the fetal hemoglobin, found at around 1% in human body. And then there's your 2 alpha chain along with alpha, beta, gamma, delta globin chain. This is hemoglobin A2, found less than 3.5% in human body. So these are the 3 normal types of hemoglobin found in human body, out of which this is the most dominant one. The one containing 2 alpha chain and 2 beta chain, 95 to 98%. What is the reason behind sickle cell anemia? It is hereditary, that is by birth genetic disorder occurs such that the beta chain gets mutated, the normal RBC gets converted into sickle cell RBC and you have sickle cell anemia. Pathogenesis. Okay, now the big picture. What actually happens in anemia? Okay, I'm gonna get from the itty bitty stuff to the large stuff, from small point to large point, from gene to RBC and then protein and then RBC itself. Let's start with DNA. So you have a normal DNA that codes for a normal protein that makes normal hemoglobin for a normal biconcave red blood cell. Then you have another DNA which is mutated, which codes for mutated protein, which makes mutated hemoglobin, which makes mutated red blood cell. So how does this mutation occur? First, there's your DNA, right? The DNA, it obviously contains nitrogen bases. These nitrogen bases, they are present in a collection of 3 or triplet. And this one triplet is also called one codon. The significance is that one codon codes for a single amino acid during transcription and translation. So there are codons. In chromosome number 11, so this is your chromosome number 11. There's your DNA. In the DNA, there are codons. In the sixth codon of chromosome number 11, point mutation occurs. What type of mutation? Point mutation occurs. So in chromosome number 11, in the DNA at the level of 6th codon, point mutation occurs. This is how. So there's your normal codon, there's your normal stuff, and then there's your mutated stuff. So in the DNA at 6th codon, the triplet that is present or the codon that is present is CTC. But during point mutation, this T, thymine, gets replaced by adenine. This DNA, during central dogma of life or during the process of formation of protein, the DNA, it forms mRNA by transcription, and then mRNA forms amino acid by translation, and these amino acids, they combine to form protein. I hope you know this much basic stuff. So by transcription, in mRNA, CTC gives complementary nitrogen base pairs, right? So C gives G, T gives A, C gives G. You get GAG, which is normal. The mutated codon, on the other hand, C gives G, C gives G, but then A gives U. Complement nitrogen base pair for A is U in mRNA. Now, GAG, it codes for amino acid glutamic acid. GUG codes for amino acid valine. So once point mutation occurs in the chromosome at the level of 6th codon of DNA, after central dogma of life, the amino acid that is formed is not glutamic acid. Glutamic acid is substituted by valine. So if you look at the series of amino acids in the beta chain of hemoglobin, the series of amino acid at 6th level, instead of glutamic acid, there is valine. See. So there's your normal beta chain of hemoglobin at 1, 2, 3, 4, 5, 6. At 6th level, there's supposed to be glutamic acid. But then due to point mutation, in mutated beta chain of hemoglobin at 1, 2, 3, 4, 5, 6, 6th level, there is valine instead of glutamic acid. This right here is the mutated beta chain. So there's the normal hemoglobin, which is called hemoglobin A, found around 95 to 98%, contains 2 alpha chain and 2 beta chain. Okay. Then after point mutation, you get mutated hemoglobin, which also contains 2 alpha chain, but then the 2 beta chains that are present are mutated. And this is called HBS. The reason being the hemoglobin is for sickle cell RBC. So sickle hemoglobin. Simple. You have your normal HbA hemoglobin and sickle hemoglobin, HBS. So the normal hemoglobin containing RBC is biconcave in structure. But then the sickle cell RBC is crescent or sickle shaped in structure. This process of conversion of normal RBC to sickle cell is called sickling. But then there is one important thing that you need to remember. Even the sickle cell RBC is not sickle cells in structure when oxygenated. When oxygenated, due to the partial pressure of oxygen inside, the RBC is distended. But when deoxygenated, carbon dioxide is taken out, the RBC becomes sickle shaped in structure during sickle cell anemia. Okay, this is what I mean. Okay, so there's your normal DNA, right? At the level of 6th codon in normal DNA, point mutation occurs. Due to this point mutation, instead of coding for glutamic acid, valine is coded, or valine substitutes glutamic acid in the beta chain. As a result, the hemoglobin gets mutated. So the hemoglobin that is to be formed is the normal hemoglobin HbA, but due to point mutation, the hemoglobin for sickle anemia formed is HbS. This HbS is present inside the red blood cell. This is red blood cell. HbS is present inside the red blood cell. In the presence of oxygen, or when red blood cell is oxygenated, due to the partial pressure present inside the red blood cell is kept distended. But once deoxygenation occurs, deoxygenation occurs, what happens is that first the HbS hemoglobin present within the RBC, they form a chain or they polymerize. HbS, 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 HbS. So they polymerize. As a result of this polymerization, long needle-like fibers are formed. Long needle-like fibers are formed. Due to the formation of these long needle-like fibers by the polymerization of HbS inside RBC, the RBC gets distorted into its sickle shape. It becomes sickle shape. It gets distorted into sickle cell. Why? Due to needle-like fibers of HbS. How was it formed? It was formed due to polymerization of HbS. Why did polymerization occur? When did it occur? After the deoxygenation of RBC. So frequently this distended RBC is converted to sickle cell when deoxygenated. When again oxygenated, the sickle cell becomes distended. So the switch takes place quite frequently. Distended, sickle cell, distended, distended, sickle cell. After so many switches take place that the membrane ruptures. Due to the rupture in the membrane, now the distended RBC gets permanently converted to sickle cell. It gets irreversibly converted into sickle cell. The same thing is given here as well. So there's your DNA. This triplet is your sixth codon. At the level of sixth codon, point mutation takes place. Adenine gets substituted by thymine. As a result, instead of coding for glutamic acid as the sixth amino acid, by the sixth codon, the DNA codes for valine as the sixth amino acid by the sixth codon, by the mutated sixth codon. So instead of getting the normal hemoglobin A, we get the mutated or sickle cell hemoglobin S. This sickle cell hemoglobin S is present inside the RBC, but then when oxygenated, the RBC is distended due to the partial pressure of oxygen inside. Once deoxygenated, the HbS, they form polymer and they form long needle-like structures. These needle-like structures, they distort the shape of RBC into sickle cell or crescent shape. But then once this cell again gets oxygenated, the HbS polymer breaks down and the RBC again gets distended due to partial pressure of oxygen inside. Due to continuous switching between the two forms of RBC, the membrane ruptures and it gets permanently or irreversibly converted into sickle cell. Now, this irreversible sickle cell is not detected by its body as one of its own, or your body does not recognize this structure. Your body recognizes this structure. So what happens to this structure? It gets hemolyzed in the spleen, and this is how hemolysis of the RBC takes place in sickle cell anemia. Hemolysis takes place. Another thing is that this sickle cell RBC is quite sticky. As a result, inside small blood vessels, they stick together and block the small blood vessel, leading to microvascular occlusion. Another thing, when the membrane ruptures, the water present inside the RBC comes out. As a result, the concentration of hemoglobin inside increases. As a result, mean corpuscular hemoglobin concentration increases. So you can see right here, these sickle cell, you can see first the normal RBC, they can flow smoothly through the tiny blood vessels, but then once they become sickle cell, they become more sticky, they stick together and occlude or block the small blood vessel, and the blood can't pass through there. There are three consequences of sickling. What is sickling? This process of conversion of RBC into sickle cell is sickling. So there are three consequences of sickling. First, occlusion in microvasculature. Due to the sticky nature of sickle cells, they occlude together and block the small blood vessels. This is occlusion in microvasculature. Second, hemolysis of sickle cell. Your body does not recognize the sickle cell. As a result, it gets hemolyzed in the reticuloendothelial system or in the macrophages of your spleen. Number 3, increased MCHC or mean corpuscular hemoglobin concentration. As the membrane ruptures, the water inside comes out. As a result, the concentration of hemoglobin increases and the mean corpuscular hemoglobin concentration also increases. So these are the 3 consequences of sickling. Then clinical features. In sickle cell anemia, clinical features occurs 1, due to the presence of anemia itself, and 2, due to the occlusion of small blood vessel or the occlusion of vessels. So first, anemia. In anemia, you can write all the general features: lethargy, easily tired, pallor, and in old ages, angina, that is chest pain, intermittent claudication, as well as muscle pain due to lack of ATP. More specific is that in hemolytic anemia, since there is destruction of RBC, there is destruction of hemoglobin, there is destruction of heme, there is production of bilirubin. The deposition of unconjugated bilirubin in your blood can cause jaundice. So hemolytic anemia is always accompanied with slight or severe jaundice most of the time. Then there are features due to vasoocclusion. So what kind of features occur due to vasoocclusion? Simple. You have your organ, you have the blood vessel supplying the organ. If the blood flow in this blood vessel is restricted, this organ gets affected and the problems occur related to the organ. Simple as that. So let's go from top to bottom one by one. One by one, we'll look at each of the organ. If the blood vessel supplying the brain gets occluded, there can be stroke and seizures. If the blood vessel supplying the eye gets occluded, there can be retinopathy. What about the cheekbones? Okay. In sickle cell anemia, hemolysis is taking place. RBCs are getting destroyed. So red cell count decreases. Obviously, your body detects that there is decrease in red cell count. So it starts to compensate by increasing erythroid cells to increase erythropoiesis. Basically, there is compensatory hyperplasia in bone marrow tissue. As a result, the cheekbones, inside cheekbones, there is compensatory hyperplasia and they become more prominent. Then restriction to blood flow to chest and abdomen can lead to chest infection, chest pain, and abdominal infection. Restriction to blood vessel supplying penis can lead to priapism. To your hand and foot, there are end arteries. So if these end arteries get blocked, your hand and foot, they swell up and they cause hand-foot syndrome. There is your femoral head supplied by blood vessel. If this blood vessel gets occluded, there is avascular necrosis of the femoral head, and there can be even more. All right. Next up, lab diagnosis. So what are the features that you are going to see upon diagnosing anemia in lab? So first is your blood findings. You draw blood, take it on a slide, or you take it in a test tube. In slide, you look at it under microscope. In test tube, you carry out CBC. So first, under microscope, this is what you're going to find. Number 1, obviously, you are going to find sickle sept cells or crescent cells, target cells, the cells of different shapes, poikilocytosis, cells of different sizes, and isocytosis. The presence of Howell-Jolly body. Then, since there is decrease in RCC, for compensation, there is compensatory hyperplasia in the bone marrow. As a result, there is more erythropoiesis and increase in reticulocyte count. RBCs are formed from, mature RBCs are formed from reticulocyte. If RBCs are getting killed, reticulocyte are getting formed continuously. Obviously, reticulocyte count is gonna get increased. Then RBC indices. Mean corpuscular volume, it remains normal. Mean corpuscular hemoglobin, it remains normal. Mean corpuscular hemoglobin concentration, it increases because there is leakage of water due to the rupture of the membrane. And red cell count, it decreases due to hemolysis. Electrophoresis shows different result for different type of allelic pair. So if there is sickle cell trait, one hemoglobin is mutated, another hemoglobin is normal. So you can find both mutated and normal hemoglobin. In sickle cell anemia, both are mutated, so you will find only mutated hemoglobin. In normal, both are normal, so you'll only find normal hemoglobin. Bone marrow finding. Obviously, since RCC decreases, there is compensatory hyperplasia, there is increase in erythroid series, erythroid cells, myeloid cells remain the same, so the ratio decreases. In spleen, see, the cells, the sickle sept cells, they are not recognized by the body, so they get hemolyzed or destroyed. They get destroyed by the reticuloendothelial system or the macrophage of your spleen. Since hemolysis is taking place in the spleen, initially spleen grows larger in size or splenomegaly occurs. But later on, due to lack of oxygen, atrophy of spleen occurs. Okay, final concept, resistance against falciparum malaria. Sickle cell anemia, it might be a bane, but for this particular thing, it's a boon as well. Why are people with sickle cell anemia resistant to falciparum malaria? This is why. So as I said earlier, even the cells of sickle cell anemia, they are distended when oxygenated due to partial pressure of oxygen. But once they get deoxygenated, they turn into sickle sept cells. So first we have your red blood cell with HBS or hemoglobin S. The parasite of Plasmodium falciparum, it enters the red blood cell. Inside the red blood cell, Plasmodium falciparum, it consumes oxygen. As a result, the partial pressure of oxygen inside decreases, or basically it becomes deoxygenated. When the mutated RBC becomes deoxygenated, it gets converted into sickle cell. This sickle cell, it gets hemolyzed in the macrophage of spleen. And this is how, along with the RBC, the parasite also gets killed. Again, there's your mutated RBC with mutated hemoglobin, but then the RBC is extended due to the presence of oxygen inside of it. The falciparum parasite, it enters the red blood cell. Inside the red blood cell, the falciparum, it starts consuming all the oxygen. As a result, the cell gets deoxygenated, or the partial pressure of oxygen decreases, and the cell which was distended gets converted into sickle cell. And this sickle cell is not recognized by the body, so it gets hemolyzed in the reticuloendothelial system or by the macrophage of your spleen. And along with the red blood cell, the parasite also gets destroyed. This is how the presence of sickle cell anemia red blood cells provide resistance against falciparum malaria. So we are done with one out of the two hemoglobinopathies. So the hemoglobinopathy that we just saw was qualitative hemoglobinopathy, that is sickle cell anemia. In sickle cell anemia, the defect in the hemoglobin occurs in terms of quality or the structure of the hemoglobin. This is what happens. A normal hemoglobin contains heme and globin. There are altogether 4 globin chains in one hemoglobin, out of which 2 are alpha chains and 2 are beta chains. In case of sickle cell anemia, mutation occurs in the beta chain. That is, in a beta chain, at the 6th position, the amino acid present is glutamic acid. But then due to mutation, due to point mutation, this glutamic acid is substituted by valine. As a result, mutation occurs in the beta chain itself. So, you had your normal hemoglobin or the adult hemoglobin containing alpha 2, beta 2. However, mutation occurs such that glutamic acid is substituted by valine. As a result, now you have alpha 2 beta mutated 2, and this is HBS or sickle cell hemoglobin. Due to the presence of sickle cell hemoglobin in the RBC, in deoxygenated condition, the RBC gets deformed into sickle cell sep. And this sickle cell sep is highly sticky and brings about occlusion in small blood vessels. And since sickle cell cells are not recognized by the body, it also gets destroyed in the reticuloendothelial system of your body. Alright, so that was the first type of hemoglobinopathy. Now let's look at the second type of hemoglobinopathy, that is quantitative hemoglobinopathy. In quantitative hemoglobinopathy, the quantity of the hemoglobin present inside the RBC is affected. How? Okay, this is how. So inside the RBC, there's your hemoglobin. Hemoglobin is composed of heme and globin chains. There are altogether 4 globin chains, 2 alpha and most of the time 2 beta. If the synthesis of these chains they are reduced, then the synthesis of globin is reduced and the synthesis of hemoglobin is reduced. This is how quantitative hemoglobinopathy occurs. And the example of it is thalassemia. So before getting into thalassemia, what happens or how exactly it happens, let's look at the 3 normal types of hemoglobin found in adult body. So in adult body, there are 3 normal types of hemoglobin. Alpha 2, beta 2 containing hemoglobin called hemoglobin A or adult hemoglobin, which is majority 95 to 98%. Second is alpha, beta, gamma. Beta is already used, now turn for alpha gamma. Alpha 2, gamma 2, which is HbF, also called fetal hemoglobin, which is found 0 to 1% in adult body. It is found at a very less percentage in adult body, but at a much high percentage in fetus. And it has a very high affinity towards oxygen. Third is alpha, beta, gamma, delta. Turn for alpha and delta. Alpha 2, delta 2, which is also called HbA2 or minor hemoglobin, found at a very minor percentage of 1.5 to 3.5%. Out of these 3 hemoglobin, the one that is found majority in human adult body is alpha 2 beta 2. In case of thalassemia, what happens is that either the synthesis of alpha chain is affected or the synthesis of beta chain is affected. What happens is either alpha chain synthesis is reduced or absent, or beta chain synthesis is reduced or absent. Depending on which chain of hemoglobin is affected, thalassemia, it's of 2 types. If alpha chain production is affected, we call it alpha thalassemia. If beta chain production is affected, we call it beta thalassemia. Okay, so overall, the funda is that there is reduced synthesis of adult hemoglobin due to reduced or absent synthesis of alpha chain or beta chain of the globin part of the hemoglobin. Okay, now let's get into the genetic pathogenesis. The majority hemoglobin found in human body, adult human body, is hemoglobin A, which contains 2 alpha chain and 2 beta chain. Alpha chain is a protein that is synthesized by a gene called alpha gene, and this alpha gene is present in chromosome number 16. Similarly, beta chain is a protein that is synthesized by the beta gene, and this beta gene is present in chromosome number 11. Again, alpha 2, beta 2. You have alpha chain, beta chain. Alpha is synthesized in chromosome number 16, beta is synthesized not in chromosome number 16, but by the gene present in chromosome number 16, and beta is synthesized by the gene present in chromosome number 11. Now, if alpha gene is affected, there is defect in the production of alpha globin leading to alpha thalassemia. Simple. If beta gene is affected, there is defect in the production of beta globin leading to beta thalassemia. Simple. Now the thing that you need to remember is, number 1, alpha gene is present in chromosome number 16. Beta gene is present in chromosome number 11. Number 2, the type of defect that occurs in these 2 genes leading to alpha thalassemia and beta thalassemia. So in case of alpha thalassemia, alpha gene gets deleted. In case of beta thalassemia, beta gene suffers point mutation. Got it? I'll revise it again once I get into alpha and beta thalassemia one by one. Okay, another thing. So there is your chromosome number 11. Here's the homologous pair. One that you get from father, another that you get from mother. One that you get from father, another that you get from mother. This is chromosome number 11 homologous pair. So in case of beta gene, it is present in homologous pair of chromosome number 11. Okay, I said earlier there's your alpha gene and beta gene in 11, alpha gene in 16. So there's your beta gene which is present in chromosome number 11. There are altogether one gene in one homologous chromosome. So altogether two genes in two homologous chromosomes. So there are altogether two genes. But in case of alpha gene, if we are talking about alpha gene present in chromosome number 16, there are altogether 4 alpha genes. 1, 2, 3, 4. 4 alpha gene. So beta-thalassemia, how does it occur? Due to point mutation to beta gene. Alpha-thalassemia, how does it occur? Due to the deletion of alpha gene. Okay, starting off with beta-thalassemia. So beta-thalassemia, it is when out of alpha to beta 2, it's the beta chain synthesis that gets affected. Either there is reduced synthesis or there is absence in the synthesis of beta globin. Okay, so for the synthesis of beta globin, there is beta gene. And this beta gene is present in chromosome number 11. How many are there? There are 2. One in each homologous chromosome. One from father, one from mother. So here's chromosome number 11. This is one homologous chromosome. Here's the beta gene. This beta gene is responsible for the production of beta globin protein. So right now, this is normal beta gene. However, in beta-thalassemia, this beta gene, it suffers point mutation. Due to point mutation, now the beta gene becomes mutated into beta-thal or beta-thalassemia. This is your abnormal or mutated beta gene. There are altogether 2 types of mutated beta gene. One that brings about reduced synthesis of beta globin, another that brings about absent synthesis of beta globin. So beta not synthesis of beta globin, beta plus reduced synthesis of beta globin. Once more, there's your chromosome number 11. This chromosome number 11 contains beta gene. This beta gene gets mutated. What type of mutation? Point mutation. Now the beta gene is converted into beta-thalassemia, which is a mutated beta gene. It is of 2 types, beta naught and beta plus. Beta naught, it stops the production of beta chain. Beta plus, it reduces the production of beta chain. That's it. What happens when the synthesis of beta globin chain is completely inhibited or reduced? So normally, in case of adult hemoglobin, HbA, you have 2 alpha and 2 beta, right? In case of beta-thalassemia, the production of beta chain is reduced or absent. As a result, beta is substituted by the other globin chains present. You have alpha, beta, gamma, delta, right? Since alpha, beta, gamma, delta. Since beta is not there, instead of beta, alpha goes or delta goes. So you can have 2 alpha and 2 gamma or 2 alpha and 2 delta. So you can either have hemoglobin F or hemoglobin A2. As a result, the percentage of fetal hemoglobin and minor hemoglobin increases in blood. Now, which increases by how much percentage, that depends on the type of beta-thalassemia. Talking about the types, let's get into it. So there are altogether 1, 2, 3 types of beta-thalassemia, depending on the severity of the disease. So most severe to least severe. Beta-thalassemia major, most severe. Beta-thalassemia intermediate, moderate. And beta-thalassemia minor, it is the least severe or silent or asymptomatic, mostly asymptomatic. Okay, first beta-thalassemia major. So in beta-thalassemia major, here is your homologous pair of chromosome. Which chromosome? Chromosome number 11. And at this position, you have your beta gene. In case of major, the most severe type of beta-thalassemia, both the beta genes, they get mutated into beta-thalassemia. Both of them get mutated, both. So what do they get mutated into? They have two options, right? Beta naught and beta plus. Beta naught, there is no synthesis. Beta plus, there is reduced synthesis. So in case of beta-thal major, mostly the type of mutation occurs such that there is homozygousness. Homozygous, that means both mutated beta gene are either beta plus or beta naught. Due to that, there is very reduced production of beta chain or absolutely no production of beta chain, leading to severe anemia and high percentage of fetal hemoglobin and minor hemoglobin. Then there's beta-thalassemia intermediate, where there is moderate severity. Here you have the same genes, right? Beta gets genetically, or beta gets mutated into the same type of genes, but then the severity or the क्या भन्छ, variation of these genes are mild. So these genes are mild variants of the same gene type, and they are also mostly heterozygous. Finally, beta-thalassemia minor. In beta-thalassemia minor, there is most of the time no symptoms at all. Even if there is mild anemia. Here it is absolutely heterozygous. So you have beta plus, that brings about less synthesis of beta chain, and another beta, this is neither beta plus, neither beta naught, that means this is normal. No mutation has occurred here. Here you have beta naught, that means there is no synthesis of beta globin by this gene, but then you have another gene, beta, which is normal, that brings about synthesis of beta globin gene. Okay. You can look at this table, with the help of which you will be able to bring relationship between homozygous, heterozygous, major, intermediate, and minor. Then pathogenesis of beta-thalassemia major. Okay, so there are three types of beta-thalassemia: major, intermediate, and minor. Since minor and intermediate, they don't bring about severe symptoms or severe anemia, we are going to look at specifically into beta-thalassemia major. What happens in beta-thalassemia major? First things first, there's your alpha 2, beta 2, right? In alpha, out of alpha and beta, in beta-thalassemia major, there is decrease in the quantity of beta or absence in the quantity of beta. There is massive decrease and massive absence in the quantity, in the amount of beta. So what happens? Alpha is lonely now. It has to get along with someone. Instead of beta, there's your gamma and delta. So alpha, it either binds with gamma, or alpha, it either binds with delta. Beta, it is either replaced by gamma, or beta, it is either replaced by delta. As a result, the amount of alpha to beta 2 reduces, that is adult hemoglobin reduces. The amount of alpha to gamma 2 increases, that is fetal hemoglobin increases, and the amount of alpha to delta 2 increases as well, or minor hemoglobin increases as well. So this is one thing that happens. Another thing, since there is defect in hemoglobin, hemolysis of red blood cell occurs, obviously, because this is a hemolytic anemia. Now, hemolysis, if it takes place in the reticuloendothelial system of the spleen, it gets inflamed, leading to splenomegaly. Second thing, since there is extravascular hemolysis, it leads to increase in quantity of unconjugated bilirubin, leading to jaundice. And if you are confused about what exactly is happening here, you have to watch the part of the video where I have explained about hemolytic anemia, intravascular and extravascular hemolysis. If you know that, this is going to be a piece of cake for you. Alright, now the RBCs have been destroyed, leading to hemolytic anemia. Since there is hemolytic anemia, there is obviously reduction in the number of red blood cells. So the body tries to compensate for the decrease in the number of red blood cells. How? By bringing about compensatory hyperplasia, that is the number of erythroid cells, it increases. As a result, the bone marrow, it becomes wider, or expansion of the bone marrow takes place. If expansion of the bone marrow within the cheekbones occur, that leads to thalassemic phases. What does it look like? I'll tell you later on in the video. Another thing, in anemia, there is massive decrease in the number of red blood cells. So the patient requires repeated blood transfusion. In repeated blood transfusion, the patient is supplied with hemoglobin. But remember, in thalassemia, the defect was in the globin of the hemoglobin, right? So there is reduction in adult hemoglobin, HbA, right? But then in case of blood transfusion, along with globin, heme is also being supplied, because hemoglobin is being supplied. Got it? See, in thalassemia, there is decreased globin. So through blood transfusion, you are trying to provide more globin. But then through blood transfusion, you are providing not just globin, you are providing hemoglobin as a whole. And hemoglobin, it provides heme as well as globin. The amount of heme in the body is normal. Now you are providing extra heme by the process of blood transfusion. As a result, the amount of iron present through the heme in the body increases, leading to iron overload, and this can lead to death. Lab diagnosis. Now there are two types of findings, blood findings and bone marrow finding. In blood finding, when you look at the smear of the blood under a microscope, or when you carry out CVC with a certain sample of blood taken, this is what you are going to find. Number one, under a microscope, you are going to see microcytic, very small RBC smaller than the nucleus of lymphocytes. Hypochromic, that is central pellar is larger than 1/3. Anisocytosis, red blood cells of different sizes. Poikilocytosis, red blood cells of different shapes. And target cells that look like target. In case of CBC carried out with blood sample, you'll see that MCV, MCH, MCHC, all of them have decreased. Upon carrying out electrophoresis, you'll see that there is increased amount of fetal hemoglobin and there is increased percentage of minor hemoglobin as well. Bone marrow findings, since there is first cellularity, since there is reduced red cell count, in order to compensate for the reduced red cell count, compensatory hyperplasia takes place. Erythroid cells increases. As a result, myeloid to erythroid ratio decreases to around 1/3. Pink inclusions occur in normoblast. Okay, you can look at the microscopy right here. You can see the target cells. They look like target. Alright, you can look at the various clinical features of alpha-thalassemia measure from top to bottom. But then the most important thing is thalassemic facies. In thalassemic facies, which is also called chipmunk facies, got the face of the children suffering with alpha-thalassemia measure resonates with that of a chipmunk face. Why? Due to frontal bossing, due to maxillary hypertrophy. Why does maxillary hypertrophy or the hypertrophy of the bone of the cheek takes place? Due to compensatory hyperplasia. Compensatory hyperplasia, the bone marrow expansion takes place in the cheekbones, leading to prominence of the cheekbone. Nasal breeze depression, maclo-occlusion due to overgrowth of maxilla, as well as the dipole. What is dipole? It is the bone marrow in the skull present in between the two tables of the skull. It widens as well, giving the chipmunk or thalassemic facies. If you look in the X-ray, you will also be able to find hair on end appearance. It seems as if hair has grown out of the skull. Why does this happen? It happens due to the widening of the dipole of the skull. Okay, there is a test for beta-thalassemia measure, and this test is called Nestrov test. But what exactly is it testing for? It is testing for the osmotic fragility of the cell. See, this is what happens. In beta-thalassemia measure, the red blood cell, its osmotic fragility decreases. This is what I mean. So you have a test tube, right? This test tube has saline water. And if you put a normal red blood cell into it, due to osmotic pressure, the red blood cell, it bursts and it ruptures. But then, if you put a red blood cell in the same saline water with thalassemia, this thalassemic red blood cell, it does not rupture. Why? Because there is a reduced fragility. It is less fragile, more strong against what? Against osmotic pressure. It's more resistance towards saline water or the saline hemolysis. The test is called naked eye single tube red cell osmotic fragility test. Naked eye because you are observing with the help of your naked eye. Single tube, you are observing at a single tube. Red cell because it's the red cell that you are effect due to red cell that you are observing. Osmotic fragility. What effect? The effect brought about by the red cell due to osmotic fragility of the red cell. Okay, let's look at the experiment itself. So there are two test tubes, 1 and 2. Both of these test tubes, they contain blood inside of them. This test tube contains normal blood. This test tube contains thalassemic blood, right? Along with that, you have also put 0.35% saline into it. Now, what happens due to saline? Due to saline, inside test tube with normal blood cells, these blood cells, due to saline, due to osmotic pressure of the saline, ruptures and deposits downward. As a result, the blood becomes transparent. In case of thalassaemic blood, what happens? The 0.35% saline is not enough to produce osmotic pressure high enough to rupture the blood vessel, to rupture the red blood cell. So the red blood cell, it remains as it is. As a result, the blood remains opaque. After 30 minutes or so of putting saline into the two blood samples, you put a paper with lines on it behind the two test tube. Now, in test tube 1 with thalassaemic blood, since the red blood cells are still intact, they are not ruptured by the saline, the blood is still opaque. As a result, the lines behind them are not visible. But then in the second test tube, the red blood cells have ruptured and settled down due to the osmotic pressure by 0.35% saline. So the blood is now transparent. As a result, the lines that are present behind are visible through them. So the lines are visible. So this is your normal, and this is thalassaemic. Okay, so we are done with beta-thalassemia. Now alpha-thalassemia. In beta-thalassemia, there was reduced or absent production of beta-globin chain. In alpha-thalassemia, there is reduced or absent production of alpha-globin chain. In beta-thalassemia, you had beta gene that went through point mutation, and the beta gene was present in chromosome number 11. Altogether, how many? 1 in each chromosome. So a total of 2 in homologous pair. In case of alpha-thalassemia, you have alpha genes responsible for the production of alpha-globin present in chromosome number 16, and there are altogether 2 alpha genes in 1 homologous chromosome and 4 alpha genes in homologous pair of chromosomes. And the type of abnormality that takes place here, or mutation that takes place here, is deletion. In beta thalassemia, point mutation; alpha thalassemia, deletion. Again, once more, beta thalassemia, alpha thalassemia. Beta gene present in chromosome number 11, alpha gene present in chromosome number 16. Beta gene, which is a total of 2 in homologous pair, alpha gene, that is a total of 4 in homologous pair. Beta thalassemia due to point mutation in beta gene, alpha thalassemia due to deletion of alpha gene. Now, there are altogether 4 alpha genes. Each of them can get deleted due to mutation in alpha thalassemia. The more the number of alpha genes that are deleted, the more severe alpha thalassemia condition is. So if 1 is deleted, it is not that severe. 2 is deleted, okay, slightly severe. 3 is deleted, severe. 4 is deleted, massively severe. Depending on that, we have 4 types of alpha thalassemia. Let's look at the 4 types. 1, 2, 3, 4. So in the first type, only 1 gene has been deleted. Only 1 alpha gene has been deleted. This is alpha thalassemia carrier, and it is asymptomatic. In the second type, out of 4, 2 have been deleted. This is alpha thalassemia trait, and there is mild anemia. In the third type, 3 out of 4 alpha genes have been deleted. So there is massive decrease in the production of alpha globin chains. This is your HbH disease. Here, since there is massive reduction in alpha globin, instead of formation of alpha 4 beta 4, the beta globin chains, they themselves tetramerize. 4 beta chain they combine and form beta 4 tetramer, and this hemoglobin is called HbH. In the fourth type, all 4 alpha genes, they are deleted. As a result, there is no alpha gene at all, and there is no production of alpha globin at all. As a result, what happens? The gamma globin chains, they tetramerize. The 4 of them combine and from gamma 4. This gamma 4 is also called HB-BART or BART hemoglobin. It is seen in hemoglobin Bart's hydrops fetalis. The name of the disease is hydrops fetalis. The type of hemoglobin is hemoglobin Bart. Again, 1, 2, 3, 4 type. First type is alpha thalassemia carrier, deletion of 1 alpha gene, asymptomatic. Second type is alpha thalassemia trait, deletion of 2 alpha gene, mild anemia. Third type is HbH disease, deletion of 3 alpha gene. There is formation of beta 4 tetramer, which is also called HbH or hemoglobin H. And the fourth type is where all 4 alpha genes are deleted. which is called hemoglobin Bart's hydrops fetalis, where tetramer of gamma, alpha beta gamma is found. This is called Bart hemoglobin. What's so significant about hemoglobin Bart and HbH? See, first there's your HbS disease, second is hydrops fetalis. In HbS disease, which is a type of alpha-thalassemia, 3 alpha genes are deleted. In hydrops fetalis, 4 alpha genes are deleted. As a result, in HbS disease, due to the deletion of 3 alpha genes, tetramer of 4 beta chains take place, leading to formation of H hemoglobin. In case of hydrops fetalis, due to the deletion of all 4 alpha genes, there is tetramer of gamma that is formed, leading to the formation of Bart's hemoglobin. Now, both HbH hemoglobin and Bart's hemoglobin, they have very high affinity towards oxygen. Since they have high affinity towards oxygen, once they bind to oxygen, they won't let go of it easily. So there is a reduced supply of oxygen to tissue, leading to hypoxia. Now, the very bad part about hypoxia is that in case of hydrops fetalis, due to this hypoxia, the fetus dies either in the uterus itself, leading to stillbirth, or few days after the fetus comes out, just few days after delivery, leading to death of the fetus itself. So this is the worst out of the 4. One of the reasons behind the cause of anemia is decreased production of red blood cell. So if there is decreased production of red blood cell, it leads to anemia. Right? Now, decreased production of red blood cell can occur due to 3 different reasons. Either because there is defect in the cytoplasm of the red blood cell, or because there is defect in the nucleus of the stem cell producing red blood cells, or there is defect in the production of stem cell itself. In cytoplasmic defect, there is defect in the hemoglobin of the red blood cell. Like in case of iron deficiency anemia, due to deficiency of iron, there is decreased production of heme. In turn, there is decreased production of hemoglobin, and in turn, there is decreased number of red blood cells. In case of thalassemia, due to mutation, there is a defective production of globin protein, that is decreased amount of alpha and beta globin protein, leading to less number of red blood cell. Either way, be it iron deficiency anemia or thalassemia, the defect is occurring in the cytoplasm of the red blood cell, leading to anemia. In nuclear defect, there is defect in the nucleus of the stem cell. Like in case of megaloblastic anemia, due to deficiency of vitamin B12 and folic acid, there is decreased synthesis of DNA. As a result, the nucleus of the stem cell, they lag behind, and the number of RBC production decreases. In these 2 conditions, in first 2 conditions, that is in case of cytoplasm defect and nuclear defect, the production of stem cell itself is not affected. See, first there is your pluripotent hematopoietic stem cell, right? This stem cell then passes through multiple stages called erythroid series. Once it forms the various types of cells of erythroid series, finally the production of matured RBCs take place. In first 2 conditions, cytoplasmic defect and nuclear defect, there is either defect in the cytoplasm of the stem cell or defect in the nucleus of the stem cell, leading to decreased production of red blood cell. However, the number of stem cell itself or the production of stem cell itself is not affected. But in stem cell defect, there is decreased production of stem cell, and due to decreased production of stem cell, there is decreased production of red blood cell. So out of the various stem cell defect leading to decreased production of red blood cell leading to anemia, we are going to look at one of them, and that is aplastic anemia. Let's begin. So aplastic anemia, first, introduction. In aplastic anemia, there is aplasia of bone marrow or bone marrow failure. Basically, your bone marrow fails to produce more stem cells. When it fails to produce more stem cells, there is decrease in the number of these stem cells. See, these stem cells, they are responsible for the production of red blood cell, white blood cell, as well as platelets. Right? So if there is decrease in the number of stem cells itself, there is decrease in the number of red blood cell, there is decrease in the number of white blood cell, and there is also decrease in the number of platelets. Decrease in the number of red blood cell leads to anemia, decrease in the number of white blood cell leads to leukopenia, and decrease in the number of platelets leads to thrombocytopenia. So the person suffers from the combination of anemia, leukopenia, and thrombocytopenia, and this condition is called pancytopenia. Cytopenia referring to cytocelpenia decrease, there is decrease in the number of cells. Pan refers to overall. For example, in case of pan-acinar, it means overall, the whole of acina of the lung. Similarly, in pancytopenia, all types of cells, they decrease in number. Why? Because there is decrease in the number of stem cell itself. The decrease in the number of cell, the father of the cell, the mother of the cell responsible for the production of these various types of cells. All right. So what are the causes behind aplastic anemia? That is, why is it that the number of stem cells decreases? Now, there are two main reasons. One, because of things happening within our body itself, that is primary aplastic anemia. And second, due to intake of external things into our body, that is secondary aplastic anemia. Within primary aplastic anemia, it could be due to genetic mutation leading to aplastic anemia by birth or congenital, or due to immune disorder leading to aplastic anemia which gets developed later on in life after birth. The congenital aplastic anemia or aplastic anemia by birth due to gene mutation is Fanconi's anemia. Fanconi's anemia. Secondary aplastic anemia could be due to drug adverse effect, like adverse effect of sulfonamides. It could be due to toxic chemicals or infections or X-rays or systemic lupus erythematosus. These various causes could cause aplastic anemia. Okay. So we know that there is decrease in the number of stem cells leading to decrease in the number of various types of other blood cells. Now we also know what causes the decrease in number of stem cells. But we need to know how exactly do the number of stem cells decrease, and that comes under pathogenesis. So initially, you have your normal stem cell, right? So this is the cytoplasm of the stem cell. This is the nucleus in the stem cell. The defect could have occurred in the cytoplasm, leading to some other conditions, other type of anemia. The defect could have occurred in your nucleus, leading to megaloblastic anemia. But that's not the case right now. Right now, you have your normal stem cell with normal cytoplasm and normal nucleus. No problem in cytoplasm and nucleus. But then, due to these various etiological factors, be it gene mutation, be it immune disorder, be it drugs, be it toxic chemicals, be it infections, be it X-rays, be it SLE, what happens is that these stem cells, they get stressed. As a result of this environmental stress, the stem cell gets modified genetically. So the stem cell is genetically altered. Once the stem cell is genetically modified, three different types of modifications are seen. 1, 2, 3. Number 1, stem cell expresses new antigens on its surface. These are new antigens expressed by stem cell on its surface due to genetic modification. Number 2, the apoptotic genes of the stem cell, they get activated. And number 3, there is decreased proliferation and differentiation. So how do they lead to decrease in the number of stem cells? See, in the third condition, there is decrease in proliferation. That is, there is decrease in division and multiplication of stem cell. And there is also decrease in differentiation. That is, there is decrease in conversion of stem cell into other types of mature blood cells, WBCs, RBCs, and platelets. As a result, there is decrease in number of stem cells and also decrease in number of other types of cells. In second condition, due to activation of apoptotic genes, apoptosis or suicide of stem cell occurs, and again there is decrease in number of stem cells. And in third condition, since stem cell has expressed new antigens on its surface,
These antigens are not recognized by your body. As a result, the T cells of your body, they secrete cytokines like interferon gamma and tumor necrotic factor to kill and destroy these stem cells. As a result, again, the number of stem cells decreases. Due to reduction in the number of stem cells, reduction in number of stem cells due to these various reasons, bone marrow aplasia occurs. Since there is reduction in number of stem cells, there is reduction in number of all sorts of mature blood cells, like red blood cell decreases, white blood cells decreases, platelets decreases, and this leads to pancytopenia. Okay, as for clinical features, simple. Since there is combination of anemia, thrombocytopenia, and leukopenia, you can write the general clinical features of all three of them. So anemia, lethargy and pallor, thrombocytopenia, clotting disorder, and leukopenia, there is infection. Finally, lab findings. So what do you do in lab finding? Number one, you draw blood out of the patient and make a peripheral smear and observe this under microscope. You take a sample of this blood and then carry out CBC, as I've said again and again and again. So that will give you your blood findings. Upon observing the peripheral smear under microscope, you can see that the red blood cells, they are normocytic and normochromic. Normocytic because their size is similar to the size of the small lymphocytes. Normochromic because there is a central 1/3 pallor which is not larger than the peripheral 2/3 red. Upon carrying out CBC, you can see that the blood cell count has decreased. RBC decreases in number, WBC decreases in number, platelet number decreases in number as well. Hemoglobin concentration decreases as well. Reticulo count decreases as well. Now, this is something that you need to know. See, in other types of anemia, where there is decrease in red cell count, a compensation takes place for the decrease in red cell count, called compensatory hyperplasia within the bone marrow. Hyperplasia. As a result, the number of erythroid cells increases. And as a result, the number of reticulocytes increases as well. However, in this condition, in aplastic anemia, since there is decrease in the number of stem cell itself, there is decrease in the number of reticulocyte count. See, again, in most of other anemia, what happened was that there was decreased in the number of red blood cell. Since there was decrease in the number of red blood cell, so there's a stem cell forming red blood cell, right? And then this stem cell gives rise to reticulocyte. So stem cell gives rise to reticulocyte, and then this reticulocyte gives rise to mature red blood cell. So in most other anemia, there was decrease in the number of red blood cell. To compensate for the decrease in the number of red blood cell, that is to increase the red blood cell, the number of reticulocyte within the body, within the bone marrow increases. However, in case of aplastic anemia, red cell count is down. Now the reti count should increase, right, in order to compensate for it. But then the number of cell that is responsible for the formation of reti count itself decreases. So basically reti count also decreases. So there is decrease in the number of reticulocyte count. Bone marrow findings. So you see that the bone marrow under a microscope shows hypocellularity. In order to observe bone marrow finding, you carry out something called bone marrow biopsy. So let's look at how exactly is this biopsy carried out. So in bone marrow biopsy, you take a bone marrow aspirate. What is aspiration? Aspiration is process of drawing something out of your body by suction, especially with the help of a needle. For example, if you take a needle and draw blood out of your vein, then that's your blood aspirate. Similarly, if bone marrow is being drawn out of your bone, then that is bone marrow aspirate. Okay. The type of biopsy that is carried out is trephined biopsy. What is trephined biopsy? In trephined biopsy, especially with the help of a second needle, a piece of bone itself is taken out, and this piece of bone still contains bone marrow inside of it. Like in this case, there is piece of bone here, right? And within this piece of bone, there is still bone marrow. Now you take this specimen and make a slide out of it and observe it under the microscope. Upon observing the slide under microscope, this is what it looks like. So there is A. A is for normal bone marrow, and there is B. B is for aplastic bone marrow or bone marrow during aplastic anemia. You can see that aplastic bone marrow is very hypocellular. These empty spaces that you see is actually fat. So in case of normal bone marrow, 50% of the spaces is fat and the remaining 50% is hematopoietic tissue. However, during aplastic anemia due to aplasia of bone marrow, lots of empty spaces are filled with fat. There's lots and lots of fat and scanty hematopoietic tissue here and there. Just scanty hematopoietic tissue. There is hypocellularity, aplasia, bone marrow, decrease in the amount of hematopoietic tissue, decrease in the number of stem cells producing the various types of red blood cells, WBCs and platelets. With that, we end the various types of anemia. But before that, I want to emphasize that you have to know this classification very well by heart, which will make the process of studying anemia a lot easier. So let's look at them. So morphologically, there are three types of anemia. Anemia with cells that are smaller than the small lymphocytes called microcytic. Anemia having red blood cells that are having size equal to small lymphocytes called normocytic. And anemia with red blood cells that are larger than the small lymphocyte called macrocytic. In microcytic, you have SITA, SITA, S for sideroblastic, I for iron deficiency anemia, T for thalassemia, and A for anemia of chronic disease. In macrocytic, you have life is hard in medical college, L for liver disease, H for hypothyroidism, M for megaloblastic anemia, and C for cytotoxic drugs. Then within normocytic, there is either, as I said earlier, increase in the number of red cell reticulocyte due to decrease in the number of red cell count, or decrease in the number of reticulocyte even though there is decrease in the number of red cell count. So you have normocytic high reticulocyte count. This is seen in SHAPE, SAPE. S for sickle cell anemia, H for hereditary spherocytosis, A for autoimmune hemolytic anemia, P for paroxysmal nocturnal hemoglobinuria, E for enzyme deficiency anemia, or G6PD deficiency anemia. So in these all cases, there is decrease in the number of red cell count due to hemolysis of red cells. That's why they are also called hemolytic anemia, which can either be intravascular or extravascular. Then there's your low reticular count, Ramchandra. R for renal failure. Here there is renal failure in normocytic. Here there is liver disease in macrocytic. So Ramchandra, renal failure, anemia of chronic disease, or aplastic anemia, M for myelofibrosis, and C for cancers. So throughout this video, I have given you a test of each type of these anemia. Under microcytic, you saw iron deficiency anemia as well as thalassemia. Under macrocytic, you saw megaloblastic anemia. Under normocytic with high reticulocyte count, you saw sickle cell anemia. And under normocytic with low reticulocyte count, you saw aplastic anemia. So now you know all the different types of anemia along with the major types of anemia in detail. With that, I want to end the lecture, and I hope the lecture was useful for you, and I want to thank you for sticking so long with this lecture.